Dr. Ashish, we can start.
Okay. Good afternoon all. I welcome you all on behalf of Alchem Laboratories, Mumbai. I'm Dr. Ashish Rajput. I'm the medical lead for OrthoNova, makers of Uprise and T-Heal. Today's our topic for our educational initiative, episode 4, OrthoNova, live hand surgery workshop. Live from Mumbai, it's a 4-hour session. We have two eminent surgeons with us, Dr. Sudhir Warrior, who is an eminent surgeon with 30 years of experience, fellowships and scholarships from Hong Kong, Japan, and Korea. His area of interest are hand and wrist afflictions, reconstructive orthopedic surgery. He has been awarded and recognized with past president of Bombay Orthopedic Society, member of hand and wrist expert from Switzerland, and he has been a member of Education Task Force from Switzerland. Welcome, sir. With him, we have Dr. Nikita Shetty. She will be assisting Dr. Sudhir Warrior, sir. She is a hand and wrist reconstructive surgeon, trained extensively under Dr. Sudhir Warrior, sir, and also at Massachusetts General Hospital. Her area of interest are hand and wrist fractures, post-traumatic and congenital hand deformity corrections, and reconstructive sports medicines. I welcome all online audience from 70 screening centers all across India. I am glad that I have 1,500 people online with us today, and I request all to download their certificates post session. Also, I would like to request everyone to ask questions in between and make the session as interactive as possible. Thank you so much, sir. Over to you.
Mic is on.
The voice is little low, sir.
Pardon?
Yes, sir. You are audible, sir. Please go on.
Yeah, you can hear me, right?
Yes, sir.
Yeah. Hi, I'm Dr. Sudhir Warrior. I'm a hand surgeon in Mumbai and with a special interest in sporting injuries of the hand and wrist. And today we are at Dr. Lard's clinic. This is like a temple for me. When I finished my MS, I joined. Yeah, when I completed my MS, I joined Dr. B.B. Joshi, who is one of the pioneers of hand surgery in India, and we worked together for 9 years, during which time we were part of the team that did a lot of work and research on JES, Joshi's external stabilization system, following which I developed an interest in injuries around the wrist and sports injuries involving the hand. With me today is Dr. Nikita Shetty. She's been with me for 5 years now, and she also has developed the same kind of interests, and she does a lot of work with me. So today we are going to operate 2 cases. The first one is a scaphoid fracture. It's an acute fracture with a proximal pole fracture. So we'll discuss that when the patient is in. We're just waiting till the anesthetist comes in. In the meanwhile, Nikita is getting ready to give a short talk on some very interesting aspects of distal radius fractures.
Yeah, when I one of the pioneers of hand surgery.
A very good afternoon, everyone. So all of us come across distal radius fractures very frequently, and with the increased use of plates in these fractures, let us understand this technique a little better. So what are the major advantages of plating a distal radius? First, it lets us restore anatomy better, and the patient can get back to quicker rehabilitation and functional activities. One second. Okay. So with the increase in use of these plates, the complication rates have been seen to go down significantly over the past few years. This is because we have been able to understand these techniques better. So a few factors that help us reduce complication rates are better understanding of the fracture patterns and their behavior, because every fracture is different. Better assessment of the injury patterns pre-operatively with very good pre-op x-rays and CT scans if necessary. Improved material and designs of implants these days, evolution of skills. The more hands-on experience you have, the better understanding of this technique. Better intra-op imaging and very focused rehabilitation programs for this patient. So which are the fractures that we need to operate? So if it's an extra-articular fractures that are displaced, that do not meet the acceptable criterias, very comminuted fractures associated with ulnar instability, osteoporotic bones, and polytrauma. And in intra-articular fractures, if there's a step of more than 2 mm, loss of articular congruity, that is both radiocarpal or radioulnar congruity, association with ulnar instability, like I mentioned, and if there are carpal injuries. So what are the few concerns that we need to address in this technique is, first is the incision. So the incision is between the FCR and the radial artery. The dissection is carefully carried out in this plane and therefore avoiding the median nerve that lies just medial to the FCR. But the disadvantage of a straight incision is that we need to retract the soft tissues to get to the ulnar corner, and because of this undue force for retraction, it causes a pressure or undue kinking of the median nerve. And many a times we've seen that these patients are not prone to hypertrophic scars, but because of the straight incision, especially along the crease, the scars tend to get hypertrophic and start getting sensitive. So what is the solution for this? We can avoid this by darting the scar at the crease and extending it only till the radial styloid. So palpate for the radial styloid, and the incision has to be till the radial styloid, darting it at the crease. And this same incision, if needed, can be extended into the palm to release the carpal tunnel. So now we have a better exposure of the ulnar corner. We do not need to retract the median nerve too much. So we reduce pressure on the median nerve, and the visualization is much better. And these scars are most of the times imperceptible. So next is the median nerve. Where does the median nerve lie? It lies just a few mm medial to the ulnar, to the FCR. So here in this patient, the median nerve was lying just under the FCR. So therefore, once you expose the FCR, avoid retracting
Sorry to interrupt you, ma'am, but the slides are not visible. The slides are not visible.
So the FCR should not be retracted until unless the Just a second, there's some problem with the
Sure, ma'am.
slide.
Sure, ma'am. Take your time.
क्यों पर इस पे तो आ रहा है? है ना? It's sharing? Okay, okay, sorry. Yeah, so like I was saying that on full screen. Yeah, and the video is also playing.
I can see a distance between FCR and median nerve like 9.57 mm, ma'am. That is the slide visible.
Yeah. So, no, the video is not playing. It's somehow not going to full screen. We're trying to fix.
Yeah. Please, can you share it into slide share, ma'am?
Stop sharing.
Slide share.
Stop here. Now open. Make it full screen. PPT. First full screen. Make my hand. Full screen. Play. Now come to the Zoom.
For Zoom, and I'll have to remove this to come to Zoom.
Okay. Share. Full screen. Yes.
Done?
Your slides are properly visible, ma'am. You can
Stop. Stop sharing.
आपका वाईफाई दो ना मुझे, अगर ऐसे तो आप लोग कैसे कनेक्ट किए? अच्छा.
Share. Entire screen. Now. Play.
Is the video playing?
you can see your camera, ma'am, not the slides. I can see you.
Share नहीं हुआ proper. Be back side.
Yes. Now I can see the desktop.
You can see the desktop.
Yeah, with the file open. You can talk here also, ma'am. No problem.
Okay, can you see this?
Yeah. Now full screen.
Just a second, ma'am. It's loading.
Done? Okay. I'm so sorry for the
No,
interruption.
it's totally okay, ma'am. It's a technical glitch. Happens.
Can you see this now?
No, it's still loading, ma'am. Yeah, ma'am. Please go on.
No, the video is not playing. Mine is playing. It's not going to full screen on this. It's just showing my desktop on that. Okay, just give us 2 minutes. We'll just solve this problem and get back to you. I'm so sorry. It's not working.
No issues, ma'am. Please take your time. Meanwhile, just check your WhatsApp, ma'am. I have shared an image that how it's visible.
Second. हाँ भाई मैं कर रही हूँ, 1 मिनट मुझे ये सब बंद करना है पहले. Copy. Oh, paste. नहीं वही तो आपके पेन ड्राइव पे नहीं जा रहा है मेरा ओपीपीटी. Then I'll do one thing. 1 second. I'll go out.
Yes.
I'll go out. Laptop. Meanwhile, we are just preparing the patient, the first patient for surgery, that is the scaphoid fracture. And we are trying to set this up. Okay. That is what I'm trying that. Is it visible now?
Yes, ma'am, it is visible. It's in full screen mode now. You can continue.
Then we stop. Sorry.
Okay, one second. One second. I'll share this only and let's see if it comes. Okay. Is it coming? Still connecting. पर आपके पेन ड्राइव पे क्यों नहीं जा रहा मेरा पीपीटी फॉर्मेट में है वो
ओपन करके रखो इसको मैडम
इसमें नेटवर्क कम है इधर ही है पर नहीं जा रहा है उस पर
फॉर्मेट है नहीं फॉर्मेट पर
फॉर्मेट का ऑप्शन नहीं आ रहा है मेरे में आपका पेन ड्राइव फॉर्मेट करने का आपका इंटरनेट कैसे कनेक्ट किया आपने तो इस पे नहीं हो सकता वो कनेक्ट अच्छा ठीक है तेरा वोडाफोन है कि ये है जियो है वोडाफोन है कर सकती हूँ
बाहर तो नेटवर्क है ना बाहर भी बैठ सकते मैडम को माइक करके दे दो मैडम अपना लैपटॉप का यूज लैपटॉप का यूज वहाँ पे नेटवर्क
है ना तो मैं इधर दरवाजा बंद कर दूँ
ये मैडम
Yes,
can
Dr.
everyone
Nikita,
hear
you
me?
can continue. Yes, I can see the screen now. Yes, ma'am. You can continue.
You can hear me?
Yes, ma'am.
Okay, and can you see my desktop?
Yes, ma'am. Perfectly fine, ma'am. Please go on.
Great. We're very sorry for the glitch.
It's okay, ma'am.
We were at the median nerve. So like I said, the median nerve is just a little medial to the FCR, and in this patient, it was right under the FCR. So you avoid retracting the FCR before you have identified the FPL. And once you have identified the FPL and then retracted it, use a very blunt Gilpey's retractor to retract the FCR and the FPL together. So this way you avoid injuring the median nerve or causing any undue pressure on the median nerve. So next comes the pronator quadratus. So this is a very, I think many people have this question, can we suture back the pronator quadratus and why should we do it? So the pronator is one, it has, the function is pronation of the forearm, and an important function of this muscle is it's a dynamic stabilizer of the DRUJ. So yes, it is important to put it back. And is it possible? It is definitely possible. If you retain the pronator while you're dissecting and going to the fracture, you can definitely put it back. So how do we do it? So you elevate the pronator from the radial border of the radius along with the periosteum in one sheet. So you avoid tearing up the pronator and therefore you retain the entire pronator, which can be sutured back. So we retain a small edge on the radial side so that we can suture back the pronator once the plate has gone on the plate, on the bone. And there's one more advantage of this. This is a patient that we went in to remove the implant that we had put. And the advantage is you know where the pronator is and you know where the plate is, and the planes are very well defined. So if you put things back, when you go in again, the planes are well defined and things are easier for you. So next is the plate placement. So what is the ideal plate placement? So George Orbe described the watershed line, that is the distal part of the radius, and the watershed line is more distal on the ulnar side than on the radial side. So now, how do we decide if the plate is well placed? So we decided with the Soong's grade. So what we do is we draw a line that goes tangential to the volar rim of the radius, and the other line that is along the shaft of the radius. So grade 0 is when this plate is lying dorsal to this red line, which we said is the line tangential to the volar lip of the radius. Grade 1 is when the plate is volar but is still proximal to this rim. And grade 2, which is a complete contraindication, that is when the plate is volar as well as distal to this rim. So what are the reasons for this? This is when the plate implant is proud, and this can cause implant related complications in the future. So what are the reasons? The reasons: 1 could be a proud screw, or 2, a thicker profile of the plate. So these are the 2 major reasons that the plate can stay off. So what happens when the plate stays off? The median nerve and the flexors lie very close to the volar rim of the radius. So if the plate is proud, it is going to impinge on these structures, and there are very high chances that these patients might have adhesional ruptures of the flexors. So here we were fixing this fracture. On the lateral view, the radius looked well reduced. The plate was looking like it was slightly off on the lateral X-ray. Only when we got the AP X-ray, we found that the plate had moved with the windshield wiper effect, and this was the reason it was not seated very well on the distal radius. So we removed these screws, we repositioned the plate, and then went on with the fixation. Now you can see that the plate is well seated on the lateral view, and in the AP view, it's in a very good position. So now what do we do if we can't get the plate to the bone? This was a 60-year-old housewife. After we reduced the fracture, we fixed it with K wires. But in spite of all our attempts, we could not get the plate to the bone. So at this point, you get the bone, the distal fragment to the plate. So how do we do it? We use intrafocal wires and then slowly push these wires to push the distal fragment to the bone. And the assistant holds these wires in this position, and we go on to fix the distal screws. The patient, the fracture went on to heal very well. The plate was well seated, and the patient did not have any implant-related complications post-op, and she regained very good functional range of motion. So here was a 32-year-old male patient with a comminuted fracture, and the cysts that you see in the lunate were completely unrelated and asymptomatic. So here, after once we got to the fracture, we got a reduction. We fixed it with temporary K wires. But when we tried to put the plate on the distal, flush to the distal fragment, the plate was staying off from the shaft. This means that the volar tilt was not corrected completely. The volar tilt was not was not tilted correctly. So how do we get this? How do we reduce this and get it to an acceptable volar tilt? So what we did here is, first we seated the plate well into the distal fragment. And like here, you are seeing that the plate is well seated to the distal fragment. It is staying a little off. So our aim right now is to correct the volar tilt and to seat this plate onto the distal fragment. At this point, we use a technique which is described as a kickstand technique. So here, what we do is, once the plate is seated on the distal fragment, we use a locking screw, like you can see in this slide. A locking screw is used in the most proximal hole of the plate to keep the plate a little off from the shaft, so that it can be brought to the distal fragment, very close to the distal fragment. Now we retain this screw, we keep the plate in this position, and then we go on to
fix the distal screws. So usually we prefer to put the first distal screw as a cortical screw so that we can get a good hold on the distal fragment. And the rest of the locking screws are introduced into the distal fragment. Once this is done and once we have confirmed that the plate is flush to the bone, next, like you can see, you can see the locking screw that is keeping the plate off. And then you can also see that we have drilled the hole for the most proximal cortical screw and we've kept that screw ready. So now we remove the kickstand screw, the locking screw that we had used to keep the plate off. We remove this. And we tighten the cortical screw. So what this does is it brings the plate close to the cortical bone and automatically the distal fragment comes forward and the volar tilt is restored. So this way we have achieved one, a good position of the plate on the distal fragment, and two, we have restored the volar tilt of the distal radius. So this is a very nice Siam image that shows how the plate is pulling the distal fragment and restoring the volar tilt. So once we do that, we go on with the fixation. And here is the plate, very well seated and flush to the bone. So this method is called the kickstand method. That is like a kickstand of a bicycle or a bike. So we use a screw to keep the plate off from the cortex. So the next is the angle and length of the screws. So the advantage of variable angle plates is that the distal holes give us a provision of 15 degrees of angulation. So we have that leeway of 15 degrees to direct the screws to go into an ideal position. So we direct these screws in a way that they lie just 2 to 3 mm proximal to the articular surface in the subchondral bone. This gives a good support to the subchondral bone. And while we're putting the styloid screw, it is always better to do it under Siam guidance. So a PA view is a good view to see where the styloid screw is being inserted. So how do we identify where the styloid is? In the PA view, I'm sure many of you know where to see for this, look for the styloid. In the lateral view, the triangle, the mountain-like structure that you're seeing on the lateral view is the styloid of the radius. So we have to make sure that the styloid screw is within the styloid. It is not going dorsal, or it's not staying volar, and it is not outside the bone. So see to it that you're aiming for the peak of the mountain. So under Siam guidance, we visualize the styloid and we aim our drill bit to go into the tip of the styloid. We drill through it and then we fix the styloid screw. Now, how do we decide what is the length of the distal screws? So one of the risks of having long distal screws is that the extensors are lying very close to the dorsal radius. So these screw tips rubbing against the extensors can cause operational rupture of the extensors, and we have seen such cases. So we have to be very careful about the length. So it has been shown that the length of the screw need not be more than the depth of the lunate. That is the length of the lunate fossa. So any screw that is longer than this is not giving us any added advantage. So this is the ideal length of the screw. So this way we avoid the screws being proud of the dorsal. Now, suppose we have a doubt that the screws are proud. How do we assess this? One is by palpation. So you palpate on the dorsum. If the screws are proud, it's pretty easy to palpate for it and to see if the screw tips are palpable on the dorsum. Two is to get good lateral tilt view. So the radius has a 20-degree inclination. So a lateral view where the wrist is placed right on the table is not a good lateral view. So because of the 20-degree inclination, we angulate the wrist to 20 degrees so that we can get a shoot-through view. So here it's an X-ray where the wrist is flat on the table, and this is 20 degrees tilt where we get the shoot-through view of the joint. So we can assess if these screws are within the joint. So here you see a shoot-through tilt lateral view of the radius, where you can see that the joint is completely clear and the screws are in the subchondral area. The third is by the Hoya's view. So what you do is we flex the elbow to 90 degrees. The arm is externally rotated and the wrist is flexed between 30 to 90 degrees, and we take a tangential view from top. Yeah. So we are looking at a tangential view of the radius, and you can see if any of these screws are proud from the dorsum, and if they are, make sure you change these screws and do not let these screws be in, because they're definitely going to rub against the extensors and give implant related complications in the future. So a closer look at the data has shown that the complication rates are more certain and implant related. So if we keep in mind all these points that we discussed today and train ourselves, we can avoid these complications. So like I said, we are the reason for the complication. So if we teach ourselves how to perform these procedures carefully and avoid complications, operative management of the distal radius is a fairly safe procedure and can give very good results, post-operative results, and easier restoration of activities. Thank you. I think we can take questions if there are any. Okay, so our first patient is prepared. So I would be joining Dr. Warrior to assist him in the surgery in the OT right now. So we'll see you inside the operating theatre.
On, eh? Can you hear me?
Yes, sir.
Yes. Okay. So the block has been given, supraclavicular block, I think. Interscalene block has been given by Dr. Pradeep Acharya, who many of you would already know is a celebrity anesthetist. He works out of Breach Candy and many other big hospitals, and is specially requested to attend surgeries and give the anesthesia for very, very important people. So we're very, very fortunate that we have Pradeep with us, and his blocks are legendary. He and his wife Sona are absolutely legends in giving blocks with one needle and a quick shot, 10 minutes, and everything is ready. So if we can, once I'm just ready, we will look at the x-rays and the history of the patient. Gloves? ये बस इधर इस पे लगा देना इधर. थोड़ा उसका लाइट कम करूं. और थोड़ा. Yes, so as you can see, this is a patient, a young patient who is 18 years old, who has had a history of a fall and has sustained a fracture of his scaphoid. This is a proximal pole fracture, and on this X-ray, you can see that there seems to be a little cystic change. Now, we would suspect in such a case that there must be a problem that may have been pre-existing, but he has no symptoms, never had a history of fall, and uh, it's quite surprising. So what it tells us is that there seems to be some change in the position. So that means the scaphoid has twisted around after fracturing. The proximal pole has moved. I mean, the distal pole has moved, and therefore you're seeing a mismatch, and therefore you're seeing a cystic change. Now there is no real cyst. It's only because there's a rotation in the distal. So it's a displaced proximal pole fracture. Now, when you have a displaced fracture of the scaphoid, it's always best scrubbing karna. Fatapat. Scrub, drape, ready. So while they're scrubbing and draping, I'll take you through how I decide which fractures of the scaphoid we need to operate. Proximal pole fractures have to be operated because the chance of going into a non-union is quite high, to the extent of almost 40%, even if they are in contact with each other. Therefore, I give the option to the patient of getting a fixation done rather than wait for it and make it a difficult situation. We also know that the blood supply to the scaphoid does get affected because as you come more and more proximally, the retrograde blood supply from the ridge of the scaphoid ends up with end arteries, and those end arteries can cause a lot of can shut down, and once they shut down, there's no blood supply to the proximal pole, and that deprives its ability to try and participate in the healing process. When this happens, you get a non-union with avascular necrosis, which is a very difficult situation to treat. Suppose the fracture was a little more distal in the waist and it was not displaced, I wouldn't operate, I'd give a plaster. If it was mildly displaced by less than 2 millimeters, very difficult to make out. But if it is just mildly displaced, then also you could give a plaster and you would probably get a good result. When displacement is more, you find the rates of union dropping down. So you want to be careful and vigilant always to see that you don't miss it at the right time. Once you've decided that you want to fix it, you need to then decide with what are you going to fix it. So there are various ways of fixing scaphoids. Obviously, K-wires are something that you can use. You sometimes use multiple K-wires. One K-wire is not good enough because the whole scaphoid can then seesaw on it. You need multiple K-wires, at least 2 K-wires, and you need to bend and cut the wires so that they don't stick out of the skin. You can then give a cast on that and hold the scaphoid until it heals. K-wires are not very strong. K-wires don't cause compression. So there's a chance that the K-wires may not sometimes be the ideal thing to fix. So you need a screw. Now, if you have a screw, 75% of the scaphoid is intra-articular. And therefore, where will you put the screw? Because wherever you put a screw, if there's a head, then the head of the screw is going to be within the joint. And therefore, you need to have what are known as headless screws which sink into the scaphoid. So a headless screw that sinks into the scaphoid will have to be passed in a particular direction. Why should that happen? Because the scaphoid, if you want to understand what a scaphoid looks like, you have to imagine a cashew nut and twist the cashew nut. So just imagine you have a very soft cashew nut and you just twist it. So that is how a scaphoid lies within our bodies. Trying to pass a straight screw through that, becomes a very arduous task. Passing screws into the scaphoid therefore need to be done on a guide wire. So you need a guide wire, you need a headless screw, and there are various different types of headless screws. Now, when you want compression, there are different ways of generating compression across the fracture site, because we know that compression is a part of aiding the healing. So you need to get a little compression across the fracture site. So there are various means depending on which screw you're using. So different companies have different ways in which they can give you compression across the fracture site. Today we are going to use the headless compression screw, or the HCS, of the Synthes company, which I have been using for a while now, and I seem to have fairly good results with this screw. We also use the AccuTrack screw. We use many of the available Indian screws. The screw that we are using today has a threaded portion distally and a threaded portion proximally, and a blank space in between where there is no threads. So what happens is, when you tighten this, you can get a gliding across that smooth surface. So therefore your far threads have to cross the fracture site when you sink in the screw. So we'll see those techniques. We'll see all the necessary techniques of inserting the screw as we start the procedure. So now we are draping the patient. We are almost ready with that. I did not talk about the MRI. Now, would you do an MRI in a proximal pole fracture? The first thought that comes to mind is that you want to do an MRI to see whether the blood supply is there or not. But in an acute fracture, there's no question, because it's so fresh. There will be, and if you see an MRI, this is what you'll see. So you'll see that all the carpal bones are like lit up from inside. They look like they're lit up, whereas the scaphoid looks, in a T1 this thing of the MRI, you will find that the scaphoid looks like it's got a lot of it's a little grayish, doesn't look like the same color. When we move to the T2, that's where you can see the blood supply. So if you see the T2, ye wala batana zara. So when you see the T2, you see that all the other bones are black and the scaphoid looks like a blush. So this indicates that the proximal and the distal part of the scaphoid is exactly deriving the same kind of blood supply. This blush is talking about the ischemia that is there post-injury, but it is not telling you that this is avascular. It's too early for that. You have to wait for 2 to 3 months before you can find out whether the scaphoid is avascular or not by doing an MRI. When you do the MRI, you need to then add to that. To that, you need to add a dye, which is going to be taken up, a radio opaque dye, which is going to be taken up by the scaphoid. And then you see the uptake. Newer methods, when you use good MRI systems, are to inject this gadolinium and to also plot a graph as to how soon it's being absorbed, or how soon it's being seen flowing through the proximal and the distal fragments of the scaphoid. So it's called dynamic enhancement, contrast enhancement. So you need a contrast and you need to plot it against a graph of time. And then you see whether the proximal pole and the distal pole get the blood supply together at the same thing. If there's no blood supply, you'll see the proximal pole, the distal pole getting blood supply, but the proximal pole, the graph will be way low than the distal pole. So therefore, you can make out whether or not the scaphoid proximal pole is being vascularized or not. And then you decide on doing a graft with a vascularized graft or any other method that you choose to do. So that is, they're almost ready there, and we'll now go to the patient.
Sir, there is a question in the chat box that what precautions should be taken pre and post operation for the stiffness of small joints in our hand. This is question from Deepak Kumar from Surat.
Can you repeat the question, please?
Yeah, sir. So, what precautions surgeons should take before going for operation for the stiffness of small joints in our hand?
Oh. So the first thing that you do is whenever you see a patient, you need to remember that the hand function, we'll just switch the cameras, that the hand function should not be compromised. So you must keep the hand moving in flexion and extension, even if you apply a cast. So even if you apply a cast, your cast will always remain beneath the distal palmar crease, as you can see here. So don't make the cast go till there, then he can't close or open his fingers. So you want to keep it here so that he's able to get a full closure there. You keep the thumb free. There's a controversy about whether to include the thumb in a scaphoid cast or not. If you want to follow those who immobilize the thumb, then what you need to do is to immobilize it in the position of function. It's called the glass holding position. So the thumb can be immobilized till the IP joint till here, leaving the IP joint completely free, and the patient able to hold a pen or a glass. So that's the glass holding position, and this is the position in which you would immobilize if you want to immobilize the thumb. There's a lot of work that tells you that there's no need for this anymore. It doesn't affect the outcomes. So a lot of people do not immobilize the thumb. But the important thing is to keep the fingers moving, irrespective of what method you're using for treating this patient. Right. So we are all ready now, painted and draped. The blood pressure of our patient is about 115. So that's the systolic pressure. So we're going to raise the tourniquet to 220 because Nikita is pointing out and saying 220. Why 220? The reason for 220 is you raise the you raise the cuff to a pressure of 80 to 100 millimeters above the level of the systolic pressure. You always palpate this radial artery before you start raising the tourniquet. So you know that the pulse, you felt the pulse, and post removal of the tourniquet, you can feel it again, especially when you're dealing with bad injuries. So we use an Eschmark tourniquet to exsanguinate. We'll then image the scaphoid once. And the reason for doing that is, number one, that you're on the correct side. Number two, that your equipment is working. Otherwise, you start your case and then the C-arm doesn't work. You could be in a little bit of trouble. Because there is a displacement, I may choose to do an open reduction and then fix it. Tourniquet on, please. So always जरा तिथे दाखव ना. उधर दिखा ना, camera उधर दिखा ना. So you see what's happening there is my theater assistant is writing down the tourniquet time. So this is written so that I can see it at all times. Abhi idhar aa jao. The next thing you must do, and these are steps not meant, I mean, it's not for show. We always do this, and that is to check that the block has acted. Once the block is acted, we're sure now we are ready to go. C-arm, please. So once you make a routine, you'll never forget any of these steps. Each step follows the other. Shooting. वो इमेज दिखा देंगे, दिखेगा नहीं. So he is just moving this camera to show you.
Camera switch.
Yeah. So you can see that we are on the right side. You can see that little gap there. And shift killer, shoot kar. Oh. So this is an oblique view, a semi-pronated view that you can see. And you can see the ST joint. You can see the scaphoid is in extension. So there's not too much of a worry there. Fine. See, I'm out. So my incision now. What happened? So we rest the wrist on a little roll of towel that makes the wrist prominent at the back like that. And then you can feel the Lister's tubercle. Now I'm going to pass a screw in the anti-grade fashion. That means from the proximal pole to the distal pole. And the reason for that is very simple again, that it's easier to go into the smaller part of the scaphoid and aim for a larger target than to go from the larger area and aim for a smaller target. So it's easier to go from the small area. So my incision is on the Lister's tubercle. So I felt the Lister's tubercle and just centered on the Lister's tubercle, more towards the wrist and a centimeter. So I'm not doing a percutaneous fixation. I am going to open it a bit because of the displacement. Skin and subcutaneous tissue are dealt with in the routine manner. You can see a large vein there. Sorry. No, you can't see the vein there. थोड़ा हाँ ऊपर से आ जाओ. Yeah, come. So here the assistant is important because the assistant can lead you away from your site. You see that? So the assistant with the retraction. Now, if I am, once again, if I am the assistant, and if I'm retracting, I can lead the surgeon away so far away from his site. So that is why every now and then you'll see me palpating the Lister's tubercle, because I don't trust Nikita at all. She's just waiting and waiting and waiting to see that I make that error, and then she'll sit and laugh. So here what you're seeing are लाइट ज्यादा है मेरे, लाइट थोड़ा कम कर दो. हाँ कमी करना लाइट. दुसरा पण कमी कर. हाँ ते राहू दे राहू दे, असंच राहू दे, असंच राहू दे, असंच राहू दे. लागलं तर नाही, लागलं तर सांगतो, तसंच राहू दे. It's a little more clear now. What you're seeing here are the supraretinacular arteries. So if I wanted to do a vascularized graft, I would have to retain these arteries. These are such small, tiny arteries on which we base the supraretinacular artery graft for avascular necrosis in scaphoid proximal poles and for Kienbock's. So here I'm going to have to sacrifice these little arteries to get to the retinaculum. So just underneath this is the retinaculum there. And I'm feeling the Lister's again. Once I'm ready, I'll cauterize this. चालू है करे? You know, there's something that I think the world over nobody can correct, and that is that the cautery will never be connected. I don't know why. Some part of the cautery mechanism will never be connected when it's time for using it. Currently, they are struggling to connect it. So I used to have a bet, standing bet with the theater staff, that the day I put my right foot out and I get the cautery pad, and when I press it, it's on 20 bipolar cautery, and I get it right, we can have a party. I promise you, I've never had to spend any money on that because they never do it. So what I'm looking for now is the EPL, which winds around the Lister's tubercle. I don't know if you can see this.
So I request the brightness is still on the higher side.
Yeah. थोड़ा और ये करेंगे. हाँ.
Now it is
Yeah.
fine.
So what we are seeing here, where my knife is a little. No, go back to the other camera. Yeah. So you see this knife here. What I'm going to now open is the EPL sheath, or the third compartment sheath. When I do this, normally Dr. Nikita doesn't believe me or trust me either. So what she does immediately is she moves the thumb. One sec, we can't see it. So slowly. So in here, you can see the EPL moving. Tenotomy scissor. So once you see the EPL moving, you know you're in the third compartment. The next thing you do is use what is known as a tenotomy scissor. So you see the tip of the scissor is blunt. It's a curved scissor. And without this scissor, I don't sit down to operate anywhere. This is a key instrument in my armamentarium, and I think all of us should have one. It's a very, very nice instrument. Now you see the EPL there, and now you can see when I'm moving the thumb. Thoda zoom out kar lo. Thoda zoom out. हाँ, और zoom out. अंगूठा दिखना चाहिए. हाँ. So now you can see I'm moving the thumb, and this tendon is moving. It's a big EPL tendon. Normally it's not so big. So that's correct. What we've got is correct. Abhi zoom in kar lena. I can't come this side. I need to just move a little bit. Sorry about this. So you see now I've opened out the compartment completely, and I've got the EPL out, and it's going to be taken away to one side. What you can now look into the wound and see is the stitch. Is the distal radius, the groove for the EPL, which is big. When you palpate, that's the end of the radius, and beneath that is where we are interested in. So we will now start dissecting that area. Knife. The tendon that you see here is the ECRB, and on the side of that one would be the ECRL, which is further down here. So the ECRL, ECRB, and we've taken out the EPL. I think we should do, na? Chal. Stitch. So we normally have Dr. Pooja, who's doing her observership with us. She also washes up, but because the camera position needed to be there, so we've asked her not to be here. So instead of her participation, what I'm doing is I'm making a retraction using sutures so that the wound will be open for me to continue working without the need for another assistant. So all four corners are secured. Sometimes during the surgery, this may come off, but it's very helpful to do this for most hand procedures. It keeps the need for another assistant. It's a very tiny place that you're working in. So you need as much freedom to move around. Self-retaining. No? This is a small self-retaining gel-P retractor, which is, again, as you can see, it's blunt. So the tips are blunt. Therefore, when you pass it like this and you stretch, you can be sure that it's not digging into anything. That now allows you a much better look to the capsule of the wrist. Feel again the Lister's tubercle. That's your guide to go down. And just distal to that, you can do a capsulotomy. In this case, I'm going to do a vertical capsulotomy, unlike when we'll be probably doing in the next case. All going well. We should have the next case, which is also a very interesting case. So there's a bit of synovium there. Which is obscuring my view. So I'm going to do a bit of synovectomy as soon as I'm inside the joint. So that's the synovium, which is blocking my view into the joint. I have opened the joint. I can see the scaphoid. I'm sure you can't, not yet. But I will show you that in a moment. Yep. Now I'm going to advance my self-retaining retractor into the wound. And I'm going to try and show you the fracture site. Can you see the fracture site? It's very, very clear. So what you're seeing, this is the fracture site. Yes. And when you flex the wrist, you'll see the proximal pole. See, now I'm extending the wrist and now I'm flexing the wrist. So when I flex the wrist, you can see the proximal pole very, very clearly. So that's why you need to be at the Lister's tubercle just beneath the listus tubercle is the scapholunate joint, which I might try and just quickly show you. So what you're looking at now, and what Dr. Nikita is pointing out, is the scapholunate ligament. So our next case deals with the scapholunate ligament, and just keep it there. Yeah. So you see when I move the wrist into radial deviation, you can see the fracture site. And as I move into ulnar deviation, what you're seeing is the scapholunate joint. So to get to the scapholunate joint, your listus tubercle is the guide. Now I'm going to just raise the roll a little bit so that I can get the wrist into much more palmar flexion. And then I'm deciding on two things now. One is to freshen up the fracture site and see whether it's good enough to just compress. There seems to be good blood supply inside there. So I don't need to do too much. I just need to try and reduce it when I'm pushing in my guide pin. I've got it almost in the position that I want, and Kisan is now going to hand me the guide pin. Guide pin, guide wire thing. Kisan is our assistant today. We have Anant and Kisan and Suhas and Santosh who are in theater with us. And Ganesh. Where's Ganesh? Ganesh is also there. Yes, Ganesh is the technical guy. Ganesh has worked with Dr. CJ Thakkar earlier. Kisan and Anant have been with us for 35, 40 years. And they've worked with Dr. BB Joshi, my guru, and with Dr. Lad, Dr. Bhende. So they're very, very experienced people. You will not hear too many things being asked for because they are one step ahead of me in most surgeries. I think. Okay. थोड़ा छोटा करना. अजून बस. काय झालं त्याला? It seems the screw check केलं याच्यावर. एक screw दाखव ना. That camera is on. I'm thinking this is on. Okay. Yeah. So now this is the screw that we are going to probably use. Oops. The kind of screw that we are going to use. Oh, sorry. Yeah, there it is. So this is the headless compression screw. And this is my guide pin. So before I put the guide pin in, I will always check that the screw can easily move on the guide pin. If I don't do that, sometimes the guide pin may be a little thicker and you may not be able to get you get the screw across the guide pin. Now the position in which I'm going to pass this is just lateral or radial to the pull the wrist down like this. Yeah. Just lateral or radial to the scapholunate joint, and I'm trying to palpate with my other hand. Thoda zoom out kar lo. Zoom out kar lo. और थोड़ा मेरा हाथ दिखने दो ना. Yeah, so this is my hand. So it's coming now and I'm holding with my thumb on the dorsum. My index finger is going on the volar side to feel the tuberosity of the scaphoid. And from this position where I am, I want to aim to hit the tuberosity. That means my finger. And that is the position in which I'm going to try and drill the guide pin. Shabi de? Now, once this is done, I cannot, you see how much flexion the wrist is in? So now I can't dorsiflex the wrist. See, ये camera जरा machine को आने देना. So now what we need to do is to check whether we are in the scaphoid, whether we are going towards, bring it this side, no? Forever. That's good. We don't want that. Sure. So now, what we are going to do is, एक मिनट कैमरा थोड़ा जूम आउट कर लेना. जूम आउट कर ले. नहीं, कौन सा दिख रहा था अभी? दोनों जरा दिखा दो. ओके, फोकस नहीं है. Yeah. So now what I'm doing is I'm lifting it up. थोड़ा zoom out करो, और zoom out, हाँ, और zoom out, हाँ. See what I'm doing? I have not changed the position of the wrist. Hey, camera. हाँ. I have not changed the position of the wrist, but I've got the scaphoid the way I want it to look. Now he's going to take a shot of the C-arm so that I don't bend the guide pin. Just shoot. So now if you एक उसमें दिखा दो कैमरा. Zoom in. एकदम नीचे ले लेना. No, also get that down. Yeah. Then it will zoom out. Shoot. Yeah. Now you can, what you're seeing is the scaphoid screw, I mean the guide pin right in the center of the scaphoid in the PA view. अभी ये कैमरा बता दो. Yeah. So now I'm going to get a lateral view. Okay. Knife. Yes. Shoot, please. Now what you see is both the views show a central position of the screw of the guide pin. So I'm a very lucky man today that it looks very nice because I've got a very large scaphoid. I've got a good exposure. I've got a guide pin that has gone down the center just with my first attempt. The pin is almost at the distal end of the scaphoid, So I'm going to make a measurement of how much of this pin is inside. And for that, we have a, abhi idhar aa jao. So now this is a measuring device which goes with the guide pins. So when you push this on and touch the surface, you just need to read off. So you can just read off how much is in. So from this, I can see that almost 24 millimeters of this guide pin is within. So it's 24 millimeters inside. It can go in a couple of millimeters more. So I think that is 26. From 26, you must remember that the other way of measuring it is Kisan is now showing me that I have to be wise and not trust anybody. So he's given me a similar wire, which I'm going to keep the blunt end onto the scaphoid, match this and see whether the reading is correct by the simple old technique that you find out that it's 24 millimeters in. So you see, the advantage of having somebody like Kisan in the theater is that I won't make a mistake because he's always there to correct me. I'm going to now, so now we are going to accept this guide pin as correct, that being in the center. अंदर जा ही नहीं रहे काय झालं हो हा निघणार ना थांब shoot Siam. So I'm just checking after pushing it those 2 millimeters in that I'm right. Almost there. That's good. The next thing I'm going to do is measure this again. Hasn't gone in at all, not too much. De jara, wire driver.
So, Dr. Warrior, we have with us HOD of SN Medical College, Agra, Dr. Chandraprakash Pal,
Welcome,
and,
sir.
and Dr. Kishore Dudat from Surat. He has joined.
Huh?
Dr. Pal and Dr. Dudat, please, sir, if you have any queries,
हा चालत नाही तो दुसरा लावून दे
requesting you to take
Pardon?
it up with Dr. I'm requesting Dr. Pal and Dr. Dudat, if they have any queries pertaining to the surgery, they can ask.
Yes,
Dr.
of course. Yes, of course. So my wire driver today is giving me a little trouble. So we have gone back to the old Jacob's chuck. So it's going to take just that little bit more time. Want to see it or just go through? So now what I'm doing is I'm driving the wire through across the STT joint to grab a hold on the bone distal to the scaphoid and checking that I've done that. Shoot. Shoot again. असं कसं दिसतंय shoot. Yeah. So now you can see my wire has gone across the STT joint so that it doesn't come out when I'm drilling. I need a hold on that side so that it doesn't come out when I'm drilling. So now I've measured 24.
Hello.
Yes. Yes. So next thing I'm going to do is decide the size of my screw. Because it was 24 and there were 2 millimeters more, I would suspect.
I request Dr. Kishore to unmute and he can ask his question.
Right. So what I'm going to do is measure 20 millimeters. Why 20 millimeters? Because I want to minus 2 for the fracture site, 2 millimeters for the fracture site to get compressed. 2 millimeters because there's a cartilage shell on top of the bone. So I want to sink my screw beneath that. So 2 millimeters for that. And 2 millimeters to be clear of the distal end. I don't need to go to that distal end. So therefore, I'm going to take a screw of 20 millimeters in this case. Now, the drill bit is marked. It's a cannulated drill bit and it's marked from 24 onwards. So there's a small laser mark at 24. In this one, it's 22. So you must always know. So sometimes it's 22, sometimes it's 24. This drill bit is marked at 22. So I need to go 2 millimeters short of that first mark. And that's what I'm going to do. Today, I will not be using a sleeve, retractor or forceps. One sec. Machine thoda मागे घेतो. Flex the wrist more.
So my question is, do
Yes.
we require derotation K wire?
Not always. In a very unstable situation, I might want to. And I'll also give you another reason why I don't use a derotation. You can't? Yeah, a derotation screw is useful when there is a very unstable situation and the bones are moving uh, uh, very unstably around one pin. Then you must put a second screw wire to stop the rotation from happening. Why I don't use it routinely? First, we'll just see this before I open my mouth. Sorry, my.
One more question, sir. Is there any maneuver to reduce if it is displaced pre-operative?
Yes, you can use K wires to try and bring it back into place,
Just like joysticking.
just like a joystick. Yes.
Thank you, sir.
So the other point about, see, now you see the drill bit is gone almost till the end. That's good enough. The rest of the threads can be cut by the screw itself. But if you pass a anti-rotation wire, the problem is if it's too close to this, when your drill is going in, the drill walls of the drill bit are very thin and the drill can burst inside. I've had that happen 2 times, after which I had to do an open surgery and bring out all that dust of metal that is there inside, because the drill bit, if you see the cannulated drill bit, it's a very thin walled device. So if there's a wire that's touching it, it can rub against that and break. So I don't like it when I don't need it. But here it's okay. Huh? Nako. Nako. He's the screw game.
So is there any study for comparison between headless compression screw and Herbert screw? Which one gives better compression?
Between headless compression screw and Herbert screw?
Yes, sir. Fully threaded headless compression screw. Tapering.
Long thread. Doni screws mala de. Yes, coming back to the question. Mosquito. Right, so my drill bit is out. I've just taken it out with my hand. Keep it flexed now. Yeah. Is there any study about the comparison of HCS versus Herbert screw? Now, both of them are compression screws. Both of them create compression by different methods. There are, I not offhand, I don't know of any study, but I remember Joseph Slade had a paper which spoke about which screw is better than the other. And the conclusion he drew from that study, this was the conclusion he drew was that it doesn't matter what screw you use, the screw has to be central. That's the main thing. Now, there are 2 types of screws that are there in my hand of the same length. I'm trying to show you that. Yes. So you can see that one of them is threaded more than the other. So there's short thread and long thread for the same length of screw. Oops. It's here. So this box comes with two screws of each size. So it's the same length of screw, but there's a short thread and there's a long thread. Now in this case, my fracture is very close to me, to my side, and there's a lot of distal part of the bone. So I'm going to use a long thread because it gives you that much more hold. But suppose your fracture was on the far surface, then you need a short thread. You need the threads to cross the fracture site. So once the threads cross the fracture site, that's how they get a good hold over there. So this is the screwdriver on which the screw has been mounted. Now the screw is mounted. So the screw is mounted onto this by just rotating it around. And now what you see is that the screw looks like a screw with a head now. So this sleeve is now like a head. And when you reach the bone, when you're putting it in and it reaches the bone, then this will work as a head to compress. So this sleeve works as the compression device in this screw. When you look at the threads of the proximal and the distal parts of the screw, they look different and you think it is differential pitch, but the differential pitch is there in the Herbert screw, but not in the HCS screw. The HCS screw has double threads proximally, and in the far end, it's got single threads, but the pitch of those threads are the same. So when you turn it around, the forward translation is equal on both sides, unlike the Herbert screw. So I've taken a 20mm screw, I've mounted it onto the screwdriver, and I'm going to now start fixing the scaphoid, during which time I'm putting pressure from the front with my finger so that I get as much of apposition of the fracture site as possible. Now when you look at, one second, turn it this way, no, the other side. Yeah. So now when you look at the screw tip, the screwdriver tip, yeah, so you can see it's almost reaching the bone, right? Now when I do this and tighten it, right? Switch kiya kya? Haan. So when I tighten it, see the head of the sleeve, the so-called head is now compressing the fracture. And I can get a nice feel of compression while I'm doing this. After that, thoda zoom out karo. इधर तक पूरा 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 इधर तक स्लीव का इसका हाँ और ऊपर और थोड़ा yeah बस. So now what you need to do is to just pull this out and then get in the long screwdriver, which has 3 marks on it, which we'll look at. Thoda zoom in kar do iske upar in a little detail. So you see there are 3 marks on this. There's the green, that is the first one. So this is the tip which is going to be used. And the first mark that you see is the green mark. The next mark is the yellow mark, and then the red mark. Yes. So, oh, sorry. So when you put this in, you can see the green mark has come to the sleeve. That means you are sitting, see right now it's not seated well. You can see the green mark jump in. That means you're seated inside the screw. When you start turning it and you come to the yellow mark, it means the screw is at the level of the scaphoid itself. We'll check this now on the C-arm. I'm going to hold this whole thing and just turn it this way. C-arm, please. Shoot. So you can see the screw has now gone in perfectly well, and there is enough for me to tighten further. अभी वापस इस पे आ जाओ. Right. So I'm going to now continue tightening till the red mark comes there. So now the red mark has just gone under. Now we'll check again on the C-arm. Should. You can see the screw now in a very good position inside.
Yes, so can you zoom it little bit, sir, for the X-ray?
Yeah.
So also, sir, I'd like to welcome Dr. Pawan Pradhan, sir. He's the HOD of Ortho Department, BRD Medical College, Gorakhpur.
Shoot, please. Welcome, sir. Machine magege. Little more.
Also, we have
That's the lateral view, the semi-pronated oblique view where you can see the screw is in the center. So we are good now. It looks like the screw is in. I'm going to remove the screwdriver. I'm going to remove this sleeve. Wire pan kad gaya. What is that? Huh? Too much inside.
Sir, can you explain some how to get a good correct position on C-arm while checking it?
Should. 1 second. Should. It's in proximally. You want to take it off or turn out. Screwdriver there. Yeah. Should please. Yeah. Okay. Should. हाँ. थोड़ा कम करना है इसको ऐसा. Should. Beautiful.
Yes, sir.
I'm thinking I'm going to push it in.
Welcome, Dr. S.P. Gupta. He is the HOD of Ortho Department for Mahatma Gandhi Medical College, Jaipur.
Welcome, sir. There was a question about how do you get good images, right?
Right, sir. How
Yeah,
about
Dr. C.P. Pal
C-arm?
from Agra.
Yeah. So we'll just. So I've removed the. You're off this. इस पे ले लेना. Switch. एक minute. So I've removed my guide pin now. I can still run the guide pin in. Take it to your chest. So that's my entry point. Yes. And now I am permitted to extend the wrist. Forceps. Right. And then we'll get our routine views and see what's happening. Forceps. Machine इकडे आण. Yep. Shoot, please. So that's the screw in position. Looks perfectly fine. Both sides in. Across the fracture site, and the threaded part is across this thing. The length of the screw is good. No part of the screw is going to hit on any articular surface. Save and shoot. And that's down the center again. So that's a very good screw and it looks perfectly fine. Nothing to worry. We are done with the surgery. We will now just machine out. We'll now just talk about the X-ray. So what we did, if we can, thoda zoom out kar le, or switch. Yeah. So what we were doing was thoda aur zoom out kar lo. Just get that light in. Yeah. Abhi switch kar lo. Yeah. So what we were doing was we were like this when we were passing the wire. There is a technique of passing the wire by looking at the scaphoid. You got to see the scaphoid as a cylinder. Very difficult. The slightest movements here and there and the whole thing gets distorted. So I don't trust that. I instead trust my finger, which goes around and feels for the tuberosity. And then I pass my wire towards my finger, to the dead center of my finger. And that's how it comes central most of the times. Now, when you have the guide pin in, what you need to do is to lift up the wrist like this till it is parallel to the table surface without moving the wrist at all. And then shoot from the top for the PA view, and then just rotate it like this with the wrist still in flexion to get your semi-pronated oblique. You could also, if you wish, get the semi-supinated view if you wish to do that as well. So these are techniques how you will be able to, without changing the flexion of the wrist, get both your views. And once you've done that, you must see that the screw is in the center on both the views. At this time, normally I would look up and ask for the tourniquet time. Yeah, so it's not too bad. A quick wash and a closure of the capsule.
So we have a question from Dr. Rakesh Solanki from Indore.
Yes.
That what should be the entry point of guide wire in the proximal pole?
Where is that?
Right.
Come. Yeah. So, Doctor, the question is?
The question is, sir, what should be the entry point of guide wire in the proximal pole? Entry point.
Yeah. Yeah. The entry point, can you, just a moment, I'm just showing you how we are going to close the capsule.
Yes, yes.
Yeah, the entry point is, as I showed you, in full palmar flexion of the wrist, complete palmar flexion of the wrist. The bottom of the scaphoid proximal pole presents itself in the incision. When you look at the ulnar side, you should be able to see the scapholunate ligament, which we saw very clearly, which Dr. Nikita showed with the forceps today. So once you see that, you have to avoid getting into that. That's the most important point. The second point is, with the palm fully flexed at the wrist, you will move at least 2 screw sizes to the lateral aspect, which means 2 screw sizes, 2 screw head sizes. So that when your screw head goes in, there's at least 1 head of screw size of intact bone, which will allow you the freedom of passing that screw without causing the scapholunate joint to be affected. So that's the entry point. Just 2 screw heads lateral to the scapholunate ligament, which you need to identify. Now, how do you identify the scapholunate ligament? You could do that with a 24 number needle. Blurred आ रहा है, थोड़ा और लाइट चाहिए, फिर वो बहुत बर्न हो जाता है. बस 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 बस, फिर भी blurred ही है. So now we are closing the capsule. We tend to reposition the EPL as well. We do not leave the EPL outside the third compartment. We close the third compartment. And the reason for doing that is, if at all you need to revisit this wrist for any reason in the future, your identification is exactly as you did when you came in the first time, which means you'll feel for the EPL, you feel for the Lister's tubercle, and you will then know where your EPL is. Suppose you have exteriorized the EPL, which a lot of texts say you should do. Then when you come in the second time, if you have to, you're lost. You don't know where you are. You're searching. And then you might injure the EPL. So I like to put it back where it was. And you can see that here. She's closed down the capsule quite well. There's one stitch to be taken a little more distally. Inverted stitches are being passed. 1 second, sorry, the other side. Yeah. Inverted stitches are being passed to close the rent in the capsule. Cut. So the capsule now is well and truly closed, after which the EPL will be repositioned into its groove. Yeah. Yeah. And the trick when you're doing that, we'll see pretty clearly in this. Yeah. Take a deep bite. Take a deep bite. So we need a deep bite. Yeah, this is overhanging. You can see it go back into the place where it was, and here's the retinaculum fibers, straight fibers here. You can see them glinting. So she's going to take a stitch there. And now, because like I said, I don't trust her. As soon as she's ready with the stitch, before she ties it up, I check the movement of the EPL. You can see the EPL is moving while she's tying it up. So it is not tying the EPL. You have to be 100% sure of this. We're using monocryl, which will dissolve in about 3 weeks' time. And between 3 and 6 weeks, it will be completely gone. It just needs to hold this while we are going to immobilize this patient in a plaster. Again, I'm moving it when the knot is being placed. So I know that the EPL is very, very free and that it is back in its house and nothing has changed for it. We've slit this across, so we'll take a couple of stitches to cover that as well. When you do that, you've restored the milieu interior of the EPL, which can then be very, very relaxed and happy. This only. Yeah. It's parallel. See? किसन थम जरा मूव कर हाँ oh. So that completes the closure. Now you can see when you look at this, I'm moving this, the incision all around this, and you can see that the anatomy has been restored. So therefore, when I come back, if I ever need to, I know I'll find everything exactly where God had placed it. Remaining stitches are removed
बस बाकी सामान ले जा
because,
और कितने
and
लोग
at this time I like to release the tourniquet, which is about 1 hour.
चाय रख दे चाय रख दे और कोई और आपका सजेशन हो कुछ तो आप मैं पूछ
So
लूंगा
the
ये पूछ
tourniquet has
लिया
been
हाँ एक
released.
कितने क्वेश्चन और चाय अपनी रख लो
I
उधर
request everyone to
और
mute
कितने
their
लोग
mic.
ले ले और फिर प्रेयर में हाँ विनोद है हाँ
Dr.
लाल
Chandra
आरती है
Prakash ji, please
दो
mute
लोग
your
हैं
mic.
Lecture, your computer is outside. Yeah. Yeah. It's there outside, no? And there's another camera there. Oh, okay. Fine. So now we just need to put in the subcutaneous stitches and the skin sutures and give the plaster. Pardon? We'll check that, yeah. In the meanwhile, I'm just going to de-wash now and get things ready for the next surgery and the next talk. So just excuse me, I'll just remove the mic.
Yes, sir, the slides are visible.
स्टार्ट कर दिया ओके अच्छा इसको ठीक है Now, while we get prepared for the second case, we have only one theater at Lard Clinic. It's a very busy theater, I must tell you. Dr. Bhinde does joint replacements. Dr. Sameer Dalvi does spine. Dr. Narvekar does arthroscopies. I do a bit of hand surgery. Dr. Amod Kale and Dr. Alex do a lot of trauma. So all in all, it's a very, very busy single theater clinic. We have 20 beds here. So while the patient is being shifted from the theater and the next patient is being taken in, we will go through something about carpal kinematics, because that is what the next case is all about. So first of all, what is carpal kinematics? Carpal kinematics, it means how do the wrist bones move? What are the ligament structures that are holding them together? And what should we know about all of this so that we can see X-rays and understand something? Maybe not initially, at least treat many of these things, but at least identify them so that they're not missed. And then when we get the expertise, we will be able to treat such cases as well. Anatomy is the king. So it's always, as you saw in the surgery, small things matter a lot. And when you talk about the wrist, the problem is you're faced with so many ligaments, just far too many ligaments to remember their names, to remember whether they are on the volar side or the dorsal side, to remember whether they are attached internally to the carpal bones or to the radius to the carpal bones. So there are internal ligaments, there are external ligaments, there are ligaments on the volar side, there are bare areas on the distal radius. So all of this makes it a very difficult thing to memorize. If you ask me which all ligaments are you seeing right now, I might find it difficult. But I learned this in 2008 when I attended the Asia Pacific Federation for Surgery of the Hand meeting. I think it was in Singapore, if I'm mistaken, not or Hong Kong. And that was my first international hand meeting that I attended. I was very fortunate to see a lecture with this slide on it and a few other slides which explain to me what is happening in the wrist. So imagine the carpal bones as these little cartoon characters holding up the hand. And that tells you the load that these bones are taking. Now, these bones continuously have to carry the load. So when you are just at rest, there's not much load. The moment you flex your hand, it starts loading the carpus against the radius. If you lift a little weight, it gets worse. And if you're in the gym, you're putting the maximum load on these bones. लवकर करायचं ना लवकर करायचं मग next case घेऊन block द्यायचंय. So this is what reminds me of the wrist bones. Once I know that this is the load, see, otherwise you're looking at an X-ray and you say, "Isme kya hai?" There's nothing there. So when I understand this, I must also understand what's happening inside there. So here are, this is 3 children who are representing the scaphoid, the lunate, and the triquetrum. The sizes are approximately the same, and I'm lucky that this is my son and my neighbor's children, and I'm lucky that their sizes were matching to what I was thinking in my mind. Many years ago, I got these children to hold their hands and stand as if they were the scaphoid, the lunate, and the triquetrum. You see right now, because they are all holding hands, they're all very happy, they're all smiling. So when the scaphoid is connected to the lunate, when the lunate is connected to the triquetrum, and all the ligaments are intact and efficient, it's a happy situation inside the wrist. These are three children who are playing in the garden, swinging from side to side. So that is what is happening inside the wrist. The scaphoid, the lunate, and the triquetrum are holding hands. One is a big bone, one is a smaller bone, and one is a tiny bone. When these bones are all moving together, they are happy. What happens inside the wrist? There are many theories about columnar theories and this and that and the other. So don't confuse your mind. Remember few basic things, and that's all I think will help you to understand what we are going to discuss in the case today. The first thing is to understand that the CMC joint, which is the joint between the metacarpals and the distal row of the carpus. As you can see here, the capitate, the hamate, the trapezium, and the trapezoid. Those joints are usually fixed completely except for the thumb. So those joints are not moving. So when the wrist moves, when you get complex movements in the wrist, what is moving? It's the proximal row on the radius and the proximal row on the distal row. The distal row is just a very stable unit. There is, if you look at it, there is about 20-30 degrees of movement at the CMC joint of the fifth metacarpal. And there is also some at the index finger, about 5 to 10 degrees. The thumb, of course, is very mobile, and that gives us other problems, but we won't discuss that. That doesn't fall into the force transmission across the wrist into the palm. So this is when they're moving around with their hands held together, they move like this. So what you're seeing now is radial deviation and ulnar deviation. And I'm going to play that again, and I want you to watch the scaphoid. इसमें mouse दिख रहा है? दिख रहा है? Okay. So you watch the scaphoid when I play this video once again. As it comes into radial deviation, what's happening to the scaphoid? Why is he changing shape? Why is the lunate changing shape? Why is the triquetrum changing shape? Let's look at it once more. So as it comes, I'm stopping the video there to show you what happens in radial deviation. The scaphoid flexes forward. It's so simple. Just remember this. In radial deviation, the scaphoid cannot go radially because the radial styloid is overhanging, and therefore it has to find some space. Otherwise, radial deviation would be deficient, would be less. So what happens is that the scaphoid flexes forwards. So the scaphoid always flexes forward. And why does this happen? So when you look at it from a lateral view, if you take a section of the radius, you find the dorsal part overhangs the palmar part by 11 degrees. So there is no place to go on top. So if scaphoid gets stuck there. And if you look at it in the AP view, you realize that the styloid is more prominent. Therefore, the scaphoid cannot move on that side. So where is the space remaining? Down. And therefore, the scaphoid flexes. Simple to understand. Now let's turn our attention to the lateral view in this. What are you seeing? You're seeing, now I want you to pay attention to the lunate. How much is the lunate moving? See where the wrist is going? We'll play this out. Sorry. We'll play this again. Okay. The wrist is moving so much up and down. But look at the lunate. Very little movement. Not at all. It's hardly moving. So the radiocarpal movement is not the wrist movement. The wrist movement involves the mid-carpal joint as well. So there's radiocarpal movement, which is some amount, and there's a lot of movement happening in the mid-carpal movement. Very, very clear. And see the scaphoid now. This is the scaphoid here. We'll see it once again. See the scaphoid, it's flexing down, and this is what happens when you go into radial deviation as well. So now you understood one more thing that's happening when the scaphoid, lunate, and triquetrum are holding their hands and they're moving together. You realize that there's more movement happening in the mid-carpal joint than in the radiocarpal joint. And there's hardly any movement happening in the CMC joints. Okay, so now you have to understand that so we can go ahead. So all of this movement gives us flexion of 70 to 90 degrees in a normal wrist. So when we examine for wrist movements, we say 70 to 90, or you say 90 degrees of flexion in my wrist, as you can see there. And extension would be a little short of that, say about 80 degrees. So you get that movement, plus you get ulnar deviation, which is more because the radius is sticking out. So there's more space on the ulnar side. The ulnar side does not have a bone. It has the TFCC, and therefore there's space for it to go to the other side. So there's 30 degrees there, and there's about 20 degrees of movement on the radial side. So this is the amount of movements that we're talking about, which we want to understand a little more in detail. And this brings us to the mid-carpal joint. Many of us don't even know it exists. Some of us know that it exists, but we don't know how much movement is occurring there. We just saw on the C-arm what was happening. So 60% of the flexion that you see in the wrist is occurring at the mid-carpal joint. That means only 40% of the movement is in the radiocarpal joint in flexion. Extension, there's 30% of the extension happening here, 30 to 40% in some texts. What does this tell you? This tells you that the mid-carpal joint is an important joint, and suppose you have a fracture of the distal radius, which is intra-articular, and it has malunited, you still find good movements in the wrist because the mid-carpal joint is moving. The mid-carpal joint is not affected in this, and therefore the mid-carpal joint enjoys its freedom to move and will therefore give you at least 60% of flexion and 30% of extension. How good is that to know? It's very good to know, because when you fixed a very tenuous fracture of the distal radius and you want to move the patient early, you tell your physiotherapist, please start the mid-carpal range and not the radiocarpal range. So if you look at your physiotherapist when you're talking and the physiotherapist looks blankly at you, then you find another physiotherapist. Because if they don't know this, this is now a theory that is there for more than 15 years, and they must know this. Your physiotherapist may not have trained in hand therapy, but wrist movements have been divided into radiocarpal movements and mid-carpal movements. So how do you tell your patient how to do this? So this is known as the dart throwing. You know, darts, where you throw a dart onto a wall where there's a target. So you throw the dart in a particular range of movement. What is that range of movement? If you just try and throw a dart just now, you can just practice this and see. You'll realize that it's in radial deviation and dorsiflexion to palmar deviation, ulnar deviation and palmar flexion. So this is the mid-carpal. Entire movement is occurring only at the mid-carpal joint. So you're not pressurizing the radiocarpal joint when you do the mid-carpal range of movements. And what are you going to get? 60 degrees of flexion and 60% of flexion and 30% of extension. So you do realize that the mid-carpal range is very, very important. Just 1 second. The patient needs to be shifted from behind me. So I'm just going to stop for a moment. Bear with me for just 2 minutes. What is that? Then get the trolley there. Get the trolley there. Drowsy? Okay, so we'll continue. आवश्यक असलं तरच कर रे. हा, नाही तर नंतर करूया. ठीक आहे. No problem. Fine. So, where were we? We were talking about the mid-carpal range. So the simplest way is to understand the mid-carpal range is the dart throwing plane. So the dart throwing plane is easy to understand. Once you establish that, let's move on. Just to now pay attention to see exactly what we were talking. Now it refreshes your memory that yes, what was discussed is very, very clear in this. So let's come back to these three, the scaphoid, the lunate, and the triquetrum. They're still very happy where we left them. But now what happens if the scaphoid and lunate become separated because they've left their hands? What are we talking about? Scapho-lunate dissociation. So when that happens, where can the scaphoid go? The scaphoid has only one place to go, and that is into flexion. As we saw, on the top, there is bone. On the radial side, there's bone. Beneath, there's nothing. So the scaphoid, as soon as the lunate leaves the hand, the scapholunate disruption occurs, scapholunate dissociation occurs, the scaphoid flexes. What happens to the lunate? Now the lunate is holding hands with the triquetrum. You see how the triquetrum is looking? The triquetrum is a very proud bone. It loves to look up. It's a tiny bone. So if you think of a little child, always looking up, always trying to grow big, always trying to act big. So the triquetrum is like that. It's a boasting bone that is very, very proud and wants to look up all the time. So it always goes into extension. So now we've learned that the scaphoid goes into flexion. And the triquetrum loves to rotate into extension. But it's holding the lunate. It hasn't left the hand of the lunate. So where will the lunate go? Abhi mera naya dost triquetrum hai. Chalo, let me go with my friend. So the lunate tilts backwards. So the lunate is now looking upwards. The scaphoid is looking downwards. And therefore, you get rotary changes within the wrist when the scaphoid and the lunate have left their hands. And this is what is known as DZ. So dorsal intercalated segment instability is nothing but the lunate going with the triquetrum. Because the triquetrum rotates into extension, the lunate is now in extension, scaphoid is in flexion, therefore scapholunate angle, so many things are going to change. And when you look at the X-ray, you will find those changes. We'll come to those later. Now on the other side, suppose there's an injury on the ulnar side and the lunate and the triquetrum leave their hands. Now it's very easy to understand this because now the scaphoid, where can it go? Still it has to go into flexion. It can't go into extension. But look at the triquetrum, still wanting to go into extension. But this time the scaphoid is holding the hand of the lunate and therefore the lunate will flex with the scaphoid. When this happens, you get exactly the opposite, and this is what is known as VZ. That is volar intercalated segment instability. Such a simple thing to understand. When you see the lunate not coplanar with the capitate and the radius, if it's looking up or down, it indicates to you that there is instability in the proximal row of the carpus, which can lead to either DZ or VZ. Very, very simple. Your short notes in your exam is not difficult. Don't have to write too many things. Have to just understand this much and talk about that. So remember these connections and remember what happens. Now from there, we go on to the next level of injury. So once the scaphoid and lunate breaks away from each other and the injury continues, suppose if the injury stops at that level, you'll get a scapholunate dissociation. Beyond that, you're going to start getting ligaments around the lunate to tear. Now, when the ligaments around the lunate begin to tear, it's a little more complex to understand, so we won't go into too many details. What I'm going to only tell you is that at this stage, there are two ligaments that hold down the lunate. That is the short radiolunate and the long radiolunate ligament. And these ligaments are on the volar side. So these are the ligaments that do not leave the lunate. They are pakka dost of lunate. So they can't leave the lunate. So therefore, the lunate will hold on to that. And once the capitate tears open, like it's tearing open here, it then sits on the head of the lunate and pushes him down and kicks it out. So you get your spilled teacup sign because of this. So this is the progressive perilunate instability pattern. One leads to another, leads to the next. If the injury continues, you're going to have this problem. So these are the two ligaments that don't leave. They are volar ligaments, that is the short and the long radiolunate ligaments. They are the strong ligaments that say, I am not leaving the lunate. And 90% of the times, the lunate is held up by this and does not move further unless there's a shearing injury. Right? Now, when you have a perilunate injury, you need to identify it. How do you identify this? Now, this is again a problem because when do perilunate injuries occur? Do you see them commonly? You don't see them commonly. Why don't you see them commonly? Because it requires a large amount of injury or velocity or the disrupting power. The energy that has to be expended on the wrist is tremendous. And the structures that normally give way are the distal radius, we know that, or the scaphoid, as we just saw. So these injuries happen very commonly, or the metacarpal, or the phalanges. So depending on which angle they're falling, or where the injury is happening, it's only the polytrauma patient who has had a very severe injury that will end up with a perilunate injury. Now that patient will normally have a head injury, may have a, maybe unconscious, sometimes will have abdominal injuries, pelvic injuries, femur, tibia, something else is broken. And where does our attention therefore go? It goes to the big injuries. What is neglected is looking at the wrist. Very often the patient is not in a condition to tell you. And very often the patient tells you that there's pain. You look at it, there's swelling. They're being revived in the theater, in the casualty. So multiple IV lines have been taken. And if these IV lines are, on the same hand that is injured, you think that, oh, it must be extravasation of the IV and things like that. So you tend to forget to examine these. Now let's look at one of these. And very often in the old days, we used to get what are known as portable x-rays, which are very, very poor x-rays, and therefore bedside x-rays sometimes don't give you that image. Now, when you see this, wrist looks quite okay in the PA view. You're looking at the wrist and it looks nothing great about this one. But you look on the other side and you see, oh, I don't know what is wrong. Something is definitely wrong. Something is not looking good. Now, how do you identify what is not looking good? So what I try to make my technicians, my juniors, my fellows and students to understand is to think that these are three. This is a CT scan image or an MRI image, sorry, which shows the radius on the right side, the lunate in the middle, and the capitate in front of it. So these three bones are in the straight line. These are supposed to be in the straight, co-linear. So they are in the same line and they face towards the same side. This is very important to understand. So to remind them, what I tell them is to look for the cashew nut and the loudspeaker. Sounds like a stupid idea, but now superimpose this and see. It looks just like a cashew nut and a loudspeaker. So if the cashew nut and the loudspeaker are sitting in perfectly well, and these two are perfectly sitting in the radius, you know nothing is wrong. Now, when you look at the lateral view, you can easily see or spot the cashew nut and the capitate, which is the loudspeaker. So you know that these three bones are collinear, nothing is wrong over there. What if the loudspeaker jumps out of the cashew nut and the cashew nut gets flipped over? So that is what you see when you see a perilunate dislocation, like you're seeing very clearly in the CT scan and the X-ray. Now you can easily identify this because your mind is seeking something that it knows. You just have to seek something that you know, and you'll find when it's right or wrong. So you always have to have a mental image of what you're looking for. Otherwise, you look at that first X-ray, at this one, and you really don't know what to think about this. So now when you analyze this, you know that the lunate is not flipped forward, but the capitate is sitting dorsal to it, and there seems to be a fracture of the scaphoid here. So this is a trans-scaphoid perilunate dislocation. So this is now how you can put it together, because you now understood what happens inside the wrist. You're shifting the patient or no? That's okay, just shift block. Don't waste time. So we're just getting the next patient ready. When you have a perilunate dislocation, there are two types of perilunate dislocation. If all the bones around the lunate are not in position or sitting with the lunate, like we saw left hands with the lunate, you get a perilunate injury, which does not involve any other bone. So it's a lesser arc. The arc is very tiny. But if you have the fracture of the scaphoid, if you have a fracture of the triquetrum, if you have a fracture of the distal radius, if you have an ulnar styloid fracture, if you have a capitate fracture, then it's called a greater arc. The arc of injury now has become very large. And when this arc becomes very large, many bones are involved. And when many bones are involved, the results are often not as good otherwise. So here's a greater arc injury. Very easy to identify now that you know what this is. You're looking for scaphoid fracture. You're seeing that the lunate has moved out, and you can see the triquetrum also injured. So that's a large arc or a greater arc injury. And when you look at the lateral view, you'll find that the lunate has, the capitate has jumped out. So your kaju and your loudspeaker are not aligned anymore. So it's easy to understand. The other thing that is usually seen is if there's a scaphoid fracture, the failure of that part, the radial side of the carpus, is through the scaphoid. In such cases, the scapholunate ligament is intact. Usually. Sometimes there can be a disruption of the scapholunate injury as well, but that's very rare. So you must remember, if you see a scaphoid fracture, you should be happy that the scapholunate joint need not be repaired or is usually in place, so that you can see once you put things together. And one other thing is to understand that sometimes DZ and VZ can happen because of a malunion of a distal radius causing an adaptive change in the carpus. So what you can have is a malunion with the lunate looking up, and that's not a good position, because now the lunate looks up, the capitate looks up, the metacarpals look up, so you're always in dorsiflexion, but you want to work in the straight plane. So what will you do? You will then bring the capitate into the straight position, at which time you're causing pressure on the ligaments. And you can see the ligament of the capitolunate ligament getting stretched and torn. Therefore, you start getting pain on the dorsum, and also pain because on the volar edge of the radius, you're going to get pressure. So you're going to get pain over there, and you're going to get pain at the dorsum. So this is what happens when there's an adaptive instability of the wrist, to which the body tries to overcome and causes another problem. So when you have to understand carpal kinematics, it's not difficult. Remember, it's something that's very simple. If you just break it down to the essentials, there's so much more that's happening between each of the bones that we don't need to discuss here. There's ulnar-sided instabilities. There's just all over the wrist. There's so many instabilities that they're identifying, because now they're putting scopes inside and looking at all of this. But we don't need to get into that much detail right now, for two reasons. Number one, they're very rare. Number two, for exams for most of the postgraduates, I don't think those topics will probably come. I'm going to stop this talk here, and I'm going to tell you about what we're going to do today. Yeah. One second. Yeah. Right. So if there are any questions so far about carpal kinematics.
Right, sir. It was, I must say that it was very wonderful presentation. It was a crisp and to the point presentation. I have few questions in the chat box, but I think these are not related to the carpal kinetics. But the question is from Dr. K. Haran from Nalgonda. He wants to ask that how to manage shortening of tendons after flexor tenorrhaphy.
How to
manage shortening of tendons after flexor tenorrhaphy.
No, I didn't understand. How to this thing?
How to manage the shortening of tendons?
Shortening of tendons.
Yes, sir.
Shortening of tendons. Meaning is the tendon shortened because of the repair? If it is, then what you need to do is to start
yes, sir.
early.
As per the repair is concerned.
Okay, so then you need to start early extension so that you do not get very tight inflection. So you shouldn't, if you had to shorten and if it's too tight, it's not a good thing. It's better to put a graft, and it's always better to then start a little early mobilization and stretch it out so that you know that these tendons can stretch out. So you use that property which you don't want in a good repair, but in a repair which is too tight and causing shortening, you use that to stretch out gently.
Right, sir. And one more question is there, sir. What are the post-operative mobilization protocol you are following in your practice?
For
all the operative procedures, sir, what are the post-operative mobilization protocols you perform? Like,
there is no Ramban Aushad for this. It requires lots of thought process, the rehabilitation of hand injuries, the rehabilitation of hand fractures, the rehabilitation of wrist injuries, wrist fractures is all separate topics by themselves. But the important thing to remember is whatever procedure you're doing, you must try and get stability, number one. Number two is once you have stability, then you must start moving early. So except in tendon injuries where I tend to use the Kleinert traction method rather than the Duran and Hauser method, I would mobilize my patients very early because I try to get as good a result of stability first and then start moving them soon, because there's so many joints in between and there are ligaments between all of them. If you don't mobilize them, then the adjacent fingers or the joints in the same finger tend to get stiff very, very fast.
yes, sir. So that means you're like putting light on the physiotherapy part?
Yes, a lot of this has to do with the rehabilitation, with the physiotherapist, with splinting, with plasters. So there's a lot that needs to be done. But the idea is to keep the hand in the functional position. That means whenever you immobilize the hand, you must immobilize the fingers in MP joint flexion, the wrist in about 20-30 degrees of extension, and the thumb, as we saw earlier, in the glass holding position. So when you do that, the hand is in such a position that even if it gets a few degrees of movements above and below, you start getting the ability to oppose the thumb to the fingers. The whole idea of treating anything in the hand is to be able to bring. So what is the function of the hand? The function of the hand is to provide you a thumb post which can come in front of the fingers, against which you should be able to grasp something. So if you can do that, you've restored enough function to this patient. So while they prepare the patient, quickly I'll just show you scapholunate injuries while the block is being given. ये कैमरा स्विच कर देंगे उसके लिए, ठीक है. You had an old injury? Oh yeah. Just cover the name on the X-ray, no? Yeah, and flip this one. Right, so we are quickly going to look at scapholunate instability. We saw some of it in the previous talk, and I think so we've seen all of this, so I'm not going to go into details of this. Oh, I should have. I could have taken the talk on this. Yeah. So we'll start from this, that the scapholunate articulation has three major parts of the ligament. On the dorsum that we normally see and which we saw in the previous case is the stout ligament. Then there is the fibrocartilaginous part which resembles the lunate and the scaphoid, and you can barely make out the difference, which is why we had to change the position to show you the scapholunate joint. And then there is the anterior or the volar part, which is a little flexible ligament. So it's a softer ligament on the front side. So between the scaphoid and the lunate, the patch of ligament that is there is strong on the top, is cartilaginous at the back, and is flexible at the bottom. So that's the three parts of the scapholunate ligament. Now, when you fall on an outstretched hand with ulnar deviation, because there's so much space to move, there's also midcarpal supination, and you start getting a scapholunate dissociation. But if you see in the cadaver and you cut the entire scapholunate ligament, you just cut the whole thing off, the scaphoid doesn't go into flexion. The scaphoid doesn't fall forward as we were discussing previously. And why is that? Because there are other ligaments which are holding the scaphoid, and we saw that complex drawing at the beginning of the previous talk. So the scaphoid is held up to the trapezium and the trapezoid by the scaphotrapezial ligament. There is a radioscaphocapitate ligament. So there's a ligament that goes from the radius to the capitate and holds up the scaphoid. This is all on the volar side. And there's a scaphocapitate ligament. So the scaphoid just doesn't fall away. But if all these are involved, then the scaphoid can fall away. If these are weak in ligaments, then the scaphoid can fall away. And then you can see a scaphoid, a scapholunate injury. Now, in this patient, you can see a small gap between the scaphoid and the lunate. Now, this is not a big gap. So you must look at these joints, adjacent joints, and see the space. That's the normal space. If this is increased by twice that space, you must suspect an instability here. How can you provoke this, or how can you cause this to happen or increase the load on the scaphoid and the lunate? You ask the patient to clench the fist. So you ask this patient to clench the fist. Now, when you clench the fist, what you're doing, you make a fist like this. And when you make a fist like this, what happens is there's actual load that comes down from the metacarpal onto the capitate, onto the scapholunate ligament, which is unstable, as also are the scaphotrapezoid and all those other ligaments there. And when all of that happens, they can completely separate from each other, leave hands, and allow the scaphoid to go into flexion there. And the lunate then runs away with the trapezium into extension. Okay. So this is, we won't go into those details of that. So sometimes you may not find this happening, and that's called the pre-dynamic SLD or the scapholunate dissociation, which means basically there's no provocative evidence, only the ligament stretch, and this is identifiable through a clinical method and by doing an arthroscopy, right? The second stage is when there is a scapholunate dissociation and there is a disruption, but the ligaments are repairable. It's early and the ligaments are repairable. And the third is a chronic one. Chronic unrepairable cartilage damaged injuries where you can't reduce it, where you can't repair it, and the cartilage is damaged. So the treatment obviously for all these three are going to be completely different. How do you identify scapholunate instability? You do the Watson test. You first look for tenderness. Where will you look for tenderness? On the scapholunate joint. Now, having seen the previous case and understood where the scapholunate joint is, you know you palpate the Lister's tubercle. Just distal to that, as you drop into the wrist, from the Lister's tubercle is the scapholunate ligament. So the scapholunate ligament is there. So when you get tenderness there, you know it's either a proximal pole fracture or a scapholunate ligament injury. The X-ray will clear up this. If you still want more details, then if you still want to try and find out whether it is one or the other, then you need to try and see whether it is pre-dynamic or not. So if it's not moving, then it's a pre-dynamic one. And for that, you do the Watson test. When the two bones move out from each other, what you need to do for the Watson test is a very simple thing. When you if you pay attention to the image, to my image, then you'll see what I'm doing with my thumb. I need to push back the tuberosity of the scaphoid back. So how do you identify the tuberosity of the scaphoid? To identify the tuberosity of the scaphoid, what you need to do is to feel your pisiform. On the ulnar side, feel your pisiform and move your thumb towards the radius, towards the radial side. When you move transversely across from the pisiform, you will find the first bony prominence is your tuberosity of the scaphoid. So what you need to do is to keep the hand in ulnar deviation, press as hard as you can on the scaphoid. Don't allow it to flex, because the moment you start radially deviating, what will happen? The scaphoid has to flex, correct? So when the scaphoid has to flex, you are pushing back and saying, no, I'm not going to allow you. So Watson's test is not permitting the scaphoid to flex when you move from ulnar deviation to radial deviation. Now, where is the space? The scaphoid and lunate have left hands. Now, where is the space? Is on the back of the wrist. So it will jump out from that little overhanging roof. And that is what is Watson's test. So you'll feel a clunk where you can see this here. The Watson's test is when it's very unstable and loose, it'll jump out and it'll be very painful. So that's the tuberosity of the scaphoid. Start with ulnar deviation, press down and move it into radial deviation. So when you feel the clunk, this is one of our staff. So he doesn't have an instability, but what do you see on the C-arm? Now, when you look at the image on the left, you see the scaphoid and the lunate. The scaphoid is sleeping on the lunate. So it's already in flexion, but the wrist is in neutral. And I've done the Watson test. You can see my thumb there pushing. See, that's my thumb there. And it's pushing the scaphoid and saying, don't come forward. When I move from ulnar deviation to radial deviation, I've pushed it out behind the radius. And the clunk is there. And see now, the lunate is looking empty over there. The lunate is not overshadowed by the scaphoid because the scaphoid has jumped out on one side. So that's the scaphoid, that's the radius, that's the scaphoid, and that's the radius. See the difference? You pushed out the scaphoid from behind, and that's the Watson test positive. So the scaphoid is flexed, the lunate is extended, so you can see your DZ over here, and that's what you do. You can ballot the scaphoid and the lunate. So you hold the scaphoid and the lunate, and now we know where the scaphoid and where is the lunate. Tuberosity pakad liya, radial side of the SL joint, and on the ulnar side of the SL joint. So when you hold that and you ballot it, you can see sometimes that it is unstable. Very subtle sign. Scaphoid shift or the lines of Gilula. Here's a patient where we have applied a distractor for a distal radius fracture, and you can see that the scaphoid is moving much more than the lunate, and that is basically the scaphoid shift or the lines of Gilula getting disrupted. So the line of Gilula is the one that runs along the bones of each row and should be in a nice smooth arc. So you must refer to this lines of Gilula to understand what the scaphoid shift is. Then next and the commonest, this thing is the Terry Thomas sign. Everyone knows this. And it is basically because there was a British comedian called Terry Thomas, and he had a big space between his front teeth. And he was very famous for Carry On Doctor and Carry On series. He was one of those comedians who was there in all of those. And when we were children, we enjoyed when we were growing, we enjoyed Terry Thomas's movies without knowing that he's going to be a major part of my life in future. So what you see is like Terry Thomas's teeth there. You see, I've lost the mouse somewhere. Anyway, so you see the gap in between. The last two signs that you need to know is the ring sign and the ring and proximal pole interval. For this, what you do is you take a PA view and you see the scaphoid. Now you can see the scapholunate dissociation. You can also see the scaphoid is small. It's not that long bone that we were talking about. No, it's become so short because it's flexed forward. So a long bone like this, and if it's flexed forward, all you're going to see is a short bone. And when you see that, you see the ring. I'm going to take the ring out. It's very clear in this X-ray. So you see the ring sign. So that's the ring and the distance between the ring and the proximal pole. For this, you need to get an X-ray of correct measurement, because today we get films which are small or enlarged. You can't measure the 7 millimeters unless you have a true film. So you should have 100% true film, or you should have a measuring device on the X-ray. So that's never there. So you must ask for 100% or a true film, so they don't reduce the size. And if you've gone to your radiology department and if you've seen your X-rays, there is, in all software, there is this thing which tells you how much percentage it has been enlarged or shortened. So you keep it at 100% and then you can measure this. And if this is less than 7 millimeters between the ring and the proximal pole, that means the scaphoid is flexed. It's an indirect evidence of scapholunate dissociation. Now, quickly, what you need to do is, just 1 second. Let me just check what's happening inside. Come, ready? Block is given. Right. The next patient has been given a block and Dr. Nikita is already beginning to scrub in. So I'm going to have to quickly get ready myself and get in there and talk to you about the patient and his history. And we'll see the rest during the surgery. But what we're going to do is something that like this case where there is a scapholunate dissociation, and we are going to recreate, if we can. This is a patient who's, I think, 55 years old, and his injury is 6 months old. His injury is 6 months old. The patient is 55 years old, not the ideal patient for a reconstruction because he already has some degenerative changes in his wrist. So therefore, we will open first and then decide whether we are going to do a proximal row carpectomy or we are going to do one of these modified Brunelli or the 3LT procedure, that is 3 ligament tenodesis procedure as described by Mark Garcia Elias. So we are going to take this call on table with this case today. And this is how the procedure is done. basically, if you follow the first slide on the top, you can see that I'm bringing the scaphoid and the lunate together from that position in this patient to this position. And once it's there, then I try and fix it down, get the get a strip of the FCR, drill it through across the scaphoid to the back of the wrist. So that's the FCR coming through the scaphoid. Now we've got a bone, we've got a ligament that is holding the scaphoid in extension. Remember, the scaphoid falls in flexion. Our aim of this procedure is to keep the scaphoid in extension and bring the right surfaces against the radius so that movements can occur. And then we fix it down by anchors into, you can see two small anchors and a wire into the lunate and the scaphoid. So there are two mini anchors in there. These are Mitech mini anchors, and that's at 9 months, well maintained. The scaphoid is out to hide. There's no ring sign now. And you can see this little hole in the scaphoid over here, which from where this ligament has been created. And that's the patient's movement. What about long term? Well, if long term, I did have a patient who went on to win multiple medals for India after doing this because they thought that she had finished her career. So these results are usually very good. And the grip improves, the range of movements sometimes may be a little lesser, but they don't get arthritis very soon. So the position of the scaphoid is what is important. And what we can do is to try and do that today. And if the cartilages are not very good, then we might resort to a proximal row carpectomy rather than recreating this today. So I'm going to leave you now for another 5 minutes and get ready and get into the theater and then start all over again. Okay. Yes, I'm back. I hope you can, sorry, you can hear me. Mala gloves detos. So we have got a 55-year-old man who is had a fall 4 years ago and injured his opposite wrist. This is the opposite wrist, and he had a small ulnar styloid fracture there, and there's some irregularity in the uh, scapholunate region. But that's the opposite side. His symptomatic side is the left side. And on the left side, what we just discussed about scapholunate dissociation is pretty clear there. Now, the other things that you can see on this X-ray, of course, this is the Terry Thomas sign staring you in the face, the ring sign, the ring pole sign, so it's less than 7 millimeters there. You can see the DZ which is there, the lunate is tilted backwards like that, and the scaphoid is there, which is tilted forward. So the scapholunate angle has reduced to less than 45 degrees, and you can see that pretty clearly. On the X-ray, on the MRI, it's more subtle to try and find the ligamentous rupture, but it's pretty clear there. Yeah, so it's pretty clear over there. And you need to look at successive films to know where it is, because at some stage you're looking at the proximal pole of the scaphoid, which is peeping over those ligaments which we just saw earlier. So in addition to that, what you need to look for is where is that? Yeah. So when you look at this image, you see that there are changes in the styloid. Now this is a sign that there is stylocarpal arthritis. So, right? Yeah. So what you see is changes in the styloid. So styloid will be very, very tender. So whatever procedure you do here, it's good to do a styloidectomy, which is 7 millimeters of the styloid needs to be removed if we're doing a procedure that we plan to do. That is to reconstruct the ligament. If we are not reconstructing the ligament, and why will we not reconstruct the ligament once we open up? We will look for the surfaces, the cartilaginous surfaces. It's thinned out cartilages here, as you can see. And the good thing that is there in this X-ray, there's not much marrow edema under this radiocarpal joints. So that tells you that there is not much happening there. But if the cartilage is not healthy, we might choose to do a proximal row carpectomy rather than reconstruction and a styloidectomy. So now we'll go on to the case. The patient is prepared and ready. So as we did the last time, we're just getting things organized. I'm feeling for the radial pulse. Dr. Acharya has given the block. Yeah, Siam. Forceps. A lot of synovitis. There's a lot of synovitis here. You can see the swelling in this region. Sorry. Yeah, so there's a lot of swelling that is seen there. I was just trying the Watson test. Want to try? So Dr. Nikita is going to try the Watson test to see whether it's possible to demonstrate on the C-arm. It is. So we'll try and show you on the C-arm fluoroscopy if it shows up well. First, we'll just take a short, an X-ray to confirm the side and to confirm that our machine is working well. Too far. अजून थोडंसं थोडं पुढे पुढे यायला लागणार. बस. Should. Should. 1 second here. Yeah, so we can see the Terry Thomas sign. You can see the ring sign, the ring pole sign. You can see the styloid being a little sharp. The radial styloid is being a little sharp, beginning to become like a beak. And let's see whether we can do the 1 second. Yeah, do it and see whether you can do it in that position. Yeah. Siam continuous. No, just keep it where it was. No, don't change the position. Yeah, I'll hold, but don't change the position once. Tam, thoda maage ge. Shoot first, then shoot. Chal. Chal, आता continuous कर. We are trying to show you on. Go. Quick. I don't think it's as. You can just see the scaphoid coming out a little bit. Look here and do. पट करके एक बार कर ले. ना बंद कर. Then it will be difficult to view it. Yeah. So it's difficult to view it. We were trying, but we're not very easily. It's not very easily possible. Right. So now we are going to use the H mark machine out. Thank you. The previous case का X-rays का photo ले लिया. Yeah. Sir. Hmm. 141. चालू कर. 260. Yes. Thank you. Time 3:07. Not bad. Chalo. So as the last time, we'll take the same incision, but much bigger this time. A little longer incision than we took the last time. Centered on the Lister's tubercle, which is right there. Cautery. Oh, beautiful images. Cotton. Yeah. So what I'm doing now is I'm getting into the plane, taking the skin and the subcutaneous tissue on one side and using the knife to just separate out the fat from the retinaculum. So the subcutaneous fat is separated out from the retinaculum to give us a very good view of the entire wrist, dorsal aspect of the wrist. Pottery. So taking a little care of the vessels when you go in helps at the time you're coming out and the tunicate is released. You find that, yeah. So now here you can see the EPL in its oblique, running obliquely like this towards the distal part here. Yeah. So I'm going to open that as we did the last time. So there it is. Both our cases have very large EPLs today. That's dislocated. Now we take our stitches. Leave the EPL. Hmm. So once these stitches are in place, we will do a capsulotomy a little differently this time because we need a nice flap to close it, if at all possible, to retain that. It is possible in most cases. Detractor. So the EPL now is out of its sheath. And on this side lies the so on the side of the, you can see where my knife is, there is the EPL groove, and just by the side of the EPL groove is the posterior interosseous nerve. Mosquito? नहीं, वो पहला व्यू बेटर था. Mhm. Yeah. So you can see the posterior interosseous nerve here. I have dissected it out. You see that? So that is the posterior interosseous nerve, and it's thickened. And as Mark Garcia Elias used to like to say, when there is pain emanating from the wrist and it's in this region, these nerves resemble neuromas. Otherwise, it's very difficult to identify it. Now, what I'm doing is I'm doing a neurectomy by excising 1 centimeter of the nerve. Having done that, now I'm going to raise the entire flexors onto my side. Sorry, the extensors onto my side. Suddenly, Dr. Nikita is wondering, what am I going to do out of the ordinary? When I said flexors, she was a little worried. What is this? Synovium? There's a lot of synovium. Yeah, there's a lot of synovitis that we are seeing. So as I raise the extensors, I'm already on. Yeah. But then this kind of a flap will not help, no? So now what you're seeing here is nothing but the scaphoid which is sticking out. Feel this? Push it. Yeah, it's sitting out of the, this is the rim of the radius, and the scaphoid is sitting out there. It's completely out of the self-retaining, please. So now I'm going to create the space for my flap, for my capsular flap. There are 2 types of flaps. Remember this? Yeah. So all my extensors have gone away with my self-retaining. So it's quite clear here. See here the extensor is. And I'm going to now take all of them out using the self-retaining. So now my self-retaining holds the extensors away from me and prevents me from making any errors. So I need to make a flap opening now, and that opening will be Here are the fibers. Cautery there, cautery. Very unusual, no? A lot of vascularity in this region. Cautery लगाय झालं. So the next step is to make a capsular flap. This is called the Berger flap, where you start from the ulnar surface of the radius, that is right here, and you take that ligament, the dorsal radiocarpal ligament, and then go transversely on the dorsal intercarpal ligament, and you get a nice big window of a flap which you can take to the radial side. So always palpate so that you don't go too close to the radioulnar joint here. These ligaments are all straining to hold things inside because there's a lot of synovitis. I don't think this flap is a very robust flap. Oh. Photogenic. What I'm seeing is the scaphoid, and I'm not seeing a very good scaphoid. I'm seeing a lot of synovitis. As you can see, I'm excising some part of the synovium there. That's all synovitis. And I'm seeing a completely broken scapholunate ligament.
So what might be the etiology for this?
The trauma, he had a trauma, but he had a trauma, but unfortunately, the other side had more pain because he had a styloid fracture. He didn't probably pay too much attention to this side, and that is what has probably caused this. Now, this is a very difficult to reduce. Yeah, give photo again. Again. Thank you. So what we are seeing now is the two parts of the scapholunate ligament are gone. There is a remnant here. Oh, 1 second. Let me just turn it. Sorry. Acha, chalega. This is good. So you see this is a remnant of the scapholunate ligament, which is good. We might get a good stitch into this. And the scaphoid has flexed forward. So I'm going to pull it back like this to show you, to see how the reduction happens. So we'll expose now the lunate as well, and then we'll try and see whether it's reducible. There it is. Let's see what is happening in the radiocarpal joint. Yeah. No, the surface is good. See, articular surface. This is the top part. Yeah. So what Dr. Nikita is talking about is the capitate also showing some changes. Isan, मला एक केवायर देतो. Oh. So the surfaces are looking okay. I don't particularly feel that. Oh, the scaphoid is completely eaten up. Yes. Photo पण काढ. नहीं ये बाजू से आ सकते हैं. One sec. Take it. नहीं ठीक है. अरे वाह. इधर से ही ले लो. थोड़ा इस तरफ आ जाओ. हाँ. जूम कर दे थोड़ा. Yes. Should. Oh, that doesn't look very nice at all. There, it's very, very clear. What you're seeing now, this is bare scaphoid bone. This is the cartilage. So it's completely rubbed off. And therefore, I don't think we should be able to try to retain the scaphoid. Because whatever we do, he's going to get arthritis from rubbing against the scaphoid over there. So, no. So obviously the corresponding radial side is also rubbed off and you can feel the bone there. I'm palpating the bone there. What I need to do now is to find out if the lunate facet of the radius is still serviceable. If that is so, a proximal row carpectomy will succeed in this patient. No reconstruction for this patient because the radius, the scaphoid and the corresponding radius are completely eburnated and will not survive. So they're already quite bad. The lunate fossa looks good. So we are going to go ahead with a PRC or a proximal row carpectomy and not a reconstruction knife. So we have consented the patient for both procedures, though we have told him that we'll try and do a salvage surgery where we will try and retain the lunate, the scapholunate, this thing, junction, but traction dekh Kisan. Big retractors. बड़ा वाला दे दे.
Thank you, sir, for putting light on the consent part. That was my next question. Thank you, sir.
Always important to consent the patient for all eventualities, because whatever modality of investigations you have, they will always fall short at some stage. And you will be stuck unless you have already spoken to the patient.
That's where your experience come into picture, sir.
Not really. It's just common procedure that you have to stick to. So what I'm doing now, I don't know whether you can see too much. थोड़ा और आगे आ जाएंगे. दिख रहा है ना? हाँ. This is good. So what I'm doing now is, this is the capitate. That looks very nice. This is the scaphoid. This is the lunate. What I'm doing now is separating out the lunate from the radius and from the triquetrum here. You can see when I move the lunate back, you can see the triquetrum there. So it's a very clear view of the wrist that is being afforded by. I need to move this a little backwards. Yep. चल किशन वायर दे दो. Screw? Screw is better. Shan screw golden वाला है ना? वही दे दो. Yep. So it's always a little bit of a struggle to get better visualization in a tight wrist like this. These are थोड़ा traction दे दे. चल वो दे दे. Direct वही दे रहा है. So what I'm doing now is trying to get in a hand screw वाला drill देना पहला. एक वायर दे दे. होल नहीं मिलेगा नहीं तो.
बड़ा forceps देना.
This is the big one, no?
No.
So why is he keeping it here? You need to be careful of your instruments because you tend to use them a little roughly. Wide retractors are not come. Acha.
Wide retractor.
चल देना वायर. हाँ पहले वायर दे. Yep. So this joystick wire is going to help me to try, and it's not really helping too much, but this is one of those cases which I normally would not reserve for a demo because it's a tough one. It's a very, very heavy wrist. So you're going to see a lot of struggling. This one either. One side. Either retractor. What is this? Sorry. Periosteum दे. Brown periosteum. Screw देता. Screw दे. एक सेकंड या थोड़ा ऐसा ट्रैक्शन दे mobilizing the lunate all around.
Okay.
Cut. The lunotriquetral joint is being released. Demo. So as I open up, we're cutting the ligaments that connect. These are the intrinsic ligaments. Now the lunate is rocking free a little better. Traction there, we. And I can see the pole. To remove this.
So are you trying for blunt dissection?
No, this is a very sharp periosteum, as you can see here.
Okay.
It's almost like a knife blade. It's there on my thumb now. You see this? Sorry. You see this sharp edge? So what I'm doing is I'm cutting with this. You see the beveled end of this. So wherever I can see the ligament, I'm cutting with the knife. Where I cannot see the ligament, I insert this and I then separate out the ligament.
Right.
So that it's more visible to cut. I might eventually break the lunate into two and then take it out, or into multiple pieces and then take it out. If it's too tight, as it looks like, बड़ा वाला retractor अपना osteotomy. That's breaking it, I think. Okay. Retractor. Sorry. That's the lunate out. All surfaces well seen.
Which?
ले. एक photo ले. What do you want to see there, The luno radiolunate joint, the facet is clear. तो इधर से ले ले ऐसा, इधर से, और ये दिखना चाहिए, ये सरफेस दिखना चाहिए सफेद ना.
So how much erosion one should look for before removing the lunate or any hand bones?
Didn't get the question, please, again.
So how much erosion one should look for before going?
any erosion is bad, but what some surgeons do is to interpose. Yeah, you can see now what you're seeing here. You see this is the one second. Yeah. So on the radial side, you can see erosions there, but on the lunate side, you can see it's very smooth. The last joint to get arthritic in the wrist is the lunate facet. This is where the capitate is going to sit, and you can see the capitate here, and that capitate is going to sit at that point, and therefore it will get some movement without pain.
Right, sir.
The only other option for this is this side. The only other option for this is a fusion of the wrist, because no partial fusion is going to work. Yeah, there's a lot of synovitis. Blade badala. So we change the blade now, and then we'll remove the triquetrum next, and then finally remove the scaphoid. Some people leave the distal end of the scaphoid. We'll see how it goes today. Now you can see the triquetrum completely there. This is the triquetrum. That's the capitate, and that's the hamate. Yeah. Injection. दूसरा पेरियास्टम आपला ब्राउन वाला. See the ligament. Pradeep, all good, no? Thank you. एक मला केवाय देना. I'm just going to see whether it will be more useful to have a K-wire in there as a joystick. Dr. Nikita is very brave. She's giving counter pressure. But I think she's also very smart. She's pushing the PC form. And unless I'm completely out of control, I think she's pretty safe. There's just synovitis all along. Everywhere there's just synovitis. So it's a very good wrist. इसमें थोड़ा ट्रैक्शन दे. Hamid also looks a little affected. Is it already in that pan arthritis phase? Yeah, because of the age, it's difficult to say. Yeah. Yeah.
So what will be the follow-up medications you would like to prescribe for this patient after the operation when he goes home?
Pardon? When the patient goes home, he goes on a painkiller, one antibiotic, vitamin C I give for good healing, and nothing else. They normally will be under the effect of the block for 12 hours, after which we'll give some injectables for 12 more hours. So at 24 hours, normally the pain is well under control. Sorry, be careful. Was there a specific purpose for that question? We will also...
Right, I was looking for any input on the medications.
Pardon?
I was looking for your input on our medications, sir.
Oh, okay. It's simple aceclofenac with paracetamol and serratiopeptidase, so that there's not too much swelling. We are almost through with the triquetrum now. Just a few fibers holding it down. So that is the triquetrum. You can see the PC form. It's also showing some hibernation of cartilage inside there. So what you're seeing there, yeah. So what you're seeing there is the PC form, which also shows some changes. So now we have to remove the scaphoid and then we are done. Then we just need to close up like we did the last time. Scaphoid is a bit tricky. Mala ke wire deto. So we need a joystick to extend it. Oh. To extend the scaphoid because it's completely flexed, as you remember. And getting to the anterior ligaments near the tuberosity of the scaphoid is a very, very difficult job. So first thing, yeah. So what Dr. Nikita is doing is trying to extend the scaphoid so that it helps. Otherwise, you won't get. Now I got control of the scaphoid, which is, so that's the scaphoid as it's moving. Yeah. So now we are going to start stripping it from its ligamentous moorings from one side to the other. Naveen blade there.
So there is a question from Dr. Deepak Kumar.
Yes.
He is asking that once you decided to excise the lunate,
Yes.
if you just nibble out the bone from the center and leaving soft periosteum peripherally, making lunate small and makes it easy for full excision. That is his question. He's asking.
No. I didn't understand. What was the question?
He just want your suggestion on that when once you decided to excise the lunate.
Yes.
What if you just nibble out the bone from the center and leaving out the soft periosteum peripherally?
You mean leave it as it is?
Yeah, he just want to ask that whether it is good.
No, because there's so much of arthritis, it will all start hurting very, very soon. It will not give any relief from pain. And what brings this patient to me is restriction of movement and pain. So I have to give him a relief of that.
Also, sir, there is one question from Dr. Abhilash from Udaipur.
Yes.
Was that in soft tissue injuries, say wrist, knee or shoulder, how much actual role is there for collagen tablets? Please share your experience. You want to ask that.
Keep it open. See, keep in. Can see the ligament there. Just a minute. I'm just.
Yes, sir. Yes. Take your time.
I know. Yeah. The role of.
Yes, sir. The role of collagen in wrist, shoulder, hand surgeries.
I always prescribe collagen to most of my patients. I feel it may have a role. I certainly have patients who are very happy having taken it. Of course, I do have a large number of patients who did not benefit at all from it either. So it depends upon the stage and what else the patient is allowed to do or made to do. So I think it is a controversial topic, and I think
yes,
there is
always better than.
Yeah, I mean, if you're doing nothing and if you're not going to offer surgery, or if surgery is not indicated at that stage, then it's good to give collagen and hope that some benefit comes out of that. Nice.
Thank you, sir.
As you can see, we are practically there. अभी वो shank screw दे दे, shank screw दे दे. So I'm looking at the time and I see 4 more minutes, and I'm hoping that my scaphoid comes out in 4. If it does, then I'm a happy man. हा नाही जाऊ दे गेलं खूप गेलंय त्या बाजूने मग रिस्ट्रिक्शन होईल ना हेच थोडासा गुड There's some there in the front. Tickle you out. See this ligament there? Radius capitate on which the radius capitate ligament is very clearly seen in the depth of the wound, probably not very visualized on the camera, but that's the ligament on which the scaphoid hangs and hopes that it doesn't have to flex too much. So right now we're saving that ligament because you need to, otherwise the wrist will go away into ulnar deviation, ulnar translation. Bring it this side a little. Sorry. Yeah, I just needed to reposition that a bit. Yes. So that's the scaphoid. All three bones have come out for the first time in my life. They've come out together as a whole unit. I normally break them into bits and remove, but I'm so happy today that it's all come out. It makes me look very nice. Now, if you remember what we were talking about, yeah, this is the ridge of the scaphoid. We were here. Now, if you're passing a screw into the scaphoid, you can imagine the complexity of how you're passing the screw. So you pass a straight screw in a bone that's like a cashew nut that's twisted. Fine. So now the other thing that you must see is if you jara andar dikha denge. One second. See, now this is the space that we have created. This is the space that we have created by removing the three bones. We will just check that everything inside is okay. And when I leave traction, see where the capitate goes. It goes and sits directly into the lunate facet there. So there's good lunate facet and it's going to stay there and do wrist flexion and extension. The next step for me now is just to close the capsule after inspecting that I've removed all the small bits of bone from inside. You can see the ligaments there, see?
Yeah.
Yeah?
Yeah.
So if you look, turn it little. Sorry. No. Now you can see. You can see in the depth, the ligaments are there, which are intact. So that's what is going to prevent the wrist from moving from side to side once the lunate is in place. So once the lunate is in place, it doesn't move too much from side to side. And we need to protect this for about 6 weeks. So it's 4 o'clock. The rest of my job is just to close this capsule, put the EPL back where it came from, and close the wound and give a plaster. So I think, Anup, if everything is okay, do you want to stop the transmission right now?
Yes, sir, we can stop here.
So this is the procedure. Now, I mean, after this, we are going to keep the wrist in a plaster for 6 weeks and then mobilize the wrist. Yeah, just before you, this thing, Siam Likana. Just before we shut the transmission, we will do one thing. We'll show you a Siam image of what we were just talking about, how the capitate comes into the lunate facet. So we will just try and see whether we can show that. Should. अल्ना अल्ना कडेगे थोडा अल्ना कडेगे थोडा अल्ना कडेगे इथून फिरव ना असं फक्त आम फिरव ना शुड शुड नाही सॉरी हा सॉरी या शुड थोडं अजून पुढे घे ना तुझ्याकडे हा शुड there you are. So you can see now, I don't know why it's because the camera is at an oblique angle. थोड़ा ये monitor ऐसा घुमा ना. हाँ नहीं हाँ उस तरफ और थोड़ा हाँ अभी देख मस्त ब्यूटी जस्ट थोड़ा सा लाइट ये कर दे और कम कर दे और कम बस फर्स्ट क्लास so that's how it looks now. The capitate has come to the lunate facet which is intact. Hopefully आता जरा movement कर continuous. So I'm showing you the lateral view and how the capitate is now going to be the lunate. Bas. Machine out. Thank you.
Thank you so much, sir.
Thank you very much. I had a great time. I think Nikita joins me in saying thank you to all of you.
Yes,
And
thank you, sir.
we hope it's been useful. And we also hope that some of the things that we've discussed today remains in the memory of most of the delegates who were able to attend. Thank you very much to OrthoNova for giving me this opportunity.
Yes, sir. I would like to give the vote of thanks, sir. So good evening, one and all present online and offline. More than 1,500 doctors are online, sir. I'm glad to tell you that more than 80 medical centers are watching you currently. And we at Alchem Burgeon Nova extend our sincere thanks to the surgeon, renowned surgeon, senior orthosurgeon, guru and mentor, Dr. Sudhir Warrier, sir, for his excellent presentation and surgeries today. Also, I would like to thank Dr. Nikita Shetty and the OT staff at Lord Clinic, Mumbai. Our sincere thanks to the HOD and professor of various medical colleges and hospital who have joined offline also. Many thanks to all ortho surgeons and students who have joined online and offline. Do not forget to download your certificate, guys. This educational initiative was brought to you by the makers of Uprise and Tea Heals, Alchem Burgeon Nova, mentored by Dr. Sudhir Warrier, sir. You can watch this today's recorded session on the same website, and thank you all once again. Have a nice day ahead. Thank you, sir.
ये रहने दे चालू रहने दे रिकॉर्ड कर रहे हैं ना बस थोड़ा ये बंद कर देंगे ना उसके बाद ये कर देंगे
रिकॉर्डिंग चालू
माइक बंद कर दे
ओके सर माइक बंद सर का माइक बंद
So we can close the session.